You are live now, ma'am.
So I'll start.
Yes, ma'am.
Yeah. A very good evening to one and all of you for our ARC webinar on enhancing concepts. And this time it's about all you want to know about angiography in retinal diseases. And it's a great evening to start off with the best set of expert panel and a great set of speakers. So I'm so sure that the next 2.5 hours is going to be the most interesting session with the kind of talks and the discussions to follow. We are truly lucky to have with us on the expert panel, Dr. N.S. Muralidhar. Dr. N.S. Muralidhar is primarily a great human being and of course the eminent president of VRSI with over 3 decades of experience and being one of the most leading retinal specialists of wide acclaim. We are truly enlightened to have him with us. We have with us Dr. Guru Prasad again, who's the Director of Clinical Services and Head of Vitreoretinal Services from M.M. Joshi Eye Hospital. Again, a very prolific surgeon who's not just done any number of VR procedures, but several thousands of even cataract surgery and other anterior segment surgeons. And we look forward to his great inputs. We have with us joining shortly Dr. Moona Pide, who is the Deputy Director of the Department of VR Services from Shankar Nethralaya, Chennai. She's again a woman of great reckon and wisdom and experience to the hilt. We have with us Dr. Anand Rajendran, who is the Chief of Retina and Vitreous Services from the Arvind Eye Care Systems based in Chennai. And he was an amazing Chairman Scientific Committee in his last term, which still leaves path challenging for the next person who's taken on. And we have with us Dr. Jay Chablani, who is Associate Professor of Ophthalmology from the University of Pittsburgh School of Medicine. And again, a very renowned individual of great acclaim. We have with us joining us Dr. George Joseph Manayat, who is a consultant retina and vitreous services from the Arvind Eye Care Systems based in Coimbatore, an amazingly skilled surgeon and with great wisdom to the hilt. Moderating with me is Dr. Srinivas Joshi, a young, dynamic, versatile, amazing surgeon who's one of the leaders who's leading his M.M. Joshi Eye Hospital. And of course, a guy we look forward to a great future for this very young, dynamic guy. And he's a member ARC South and quite a right hand for me. And without wasting any time with the expert panel who are going to be discussing the various cases as has been allotted to them, we shall now go on to our first speaker, Dr. Jay. On to you, Doctor, and he's going to be talking on CSC.
Thank you so much for the kind introduction. Because I believe ARC is doing such a great job, and when we are talking about advanced imaging, I decided that we will just jump on to the OCT angio. I have recorded a video because of some time constraints, so I'll just go ahead and play the video. And if there is any difficulties in listening or not clear, let me know. Everybody, I'll be talking about OCT angiography in CSCR. These are my financial disclosure, and none of them are relevant to this presentation. I'll show a couple of examples where OCT angio could be useful in cases in CSCR. Let's start with choriocapillaries flow voids. As you can see in these pictures, the choriocapillary slab clearly shows areas of flow voids, which is a pretty common feature in CSCR eyes as well as in fellow eyes. However, if you take the segmentation deeper in the choroid, you will be able to see the deeper choroidal vessels as shown on this choriocapillary slab on the top right, where you are able to appreciate the pachyvessels, dilated choroidal vessels, and other features which we would like to see by using indocyanine green angiography. The next utility of OCT angio in CSCR is FAPET evaluation. We all have learned that there could be a flat irregular pigment epithelial detachment, which could be hyperreflective as shown on the top picture and as hyporeflective as shown on the bottom vertical scan. This is the vertical and horizontal scan of the same eye, and I will show you this eye where we were able to see the different kind of CNV formation in the hyperreflective pupil. However, the hyporeflective pupil did not show any choroidal neovascular membrane. As you can see on these pictures on fluorescein angiography, and we are not able to appreciate any network on fluorescein angiography. However, indocyanine green angiography does show some form of network, but this network of hyperreflective pupil was clearly noted on OCT angiography as shown with this yellow arrow. Let's look at how do we use OCT angiography for CNV detection. Many a times patients with CSC present with exudate as shown in this example. If you do a OCT angiography, you will be able to appreciate a choroidal neovascular network as seen in this example very easily without doing any invasive test. Let's look at the fellow eyes of CSCR with CNV. This is one of our recent paper where we showed that OCT angiography can be used to look for CNV formation in the fellow eyes of CSCR. This is one example, and this is another example where you can see that the left eye clearly shows the presence of choroidal neovascular membranes on the OCT angiography picture. We also showed in the long-term follow-up of these fellow eyes with CSR CNV that approximately 33% of these eyes tend to develop CNV on OCT angiography. What about cystoid degeneration in CSCR? This is one of the very complex situation in patients with CSCR where we are able to see the cystoid degeneration. In these cases, we showed that approximately 45% of these patients had choroidal neovascular membrane on OCT angiography, and this could be the cause for persistent fluid in these eyes. This is another example of patient with CSCR with cystoid macular degeneration, where you can see that there is a presence of CNV network on OCT angiography. Let me show you one of the very interesting case where OCT angiography was very useful. I had a 56-year-old female who presented with both eyes vision loss for last 4 years. Her right eye visual acuity was 20/25 and left eye was 20/80. These were the OCT pictures back in 2013, where we did not have OCT angiography. Here we are able to see the presence of subretinal fluid, and I suspected some form of early network on ICG. And this patient went ahead with low fluence PDT, and you can see that after low fluence PDT, the fluid resolved, and this patient showed foveal thinning, and this patient was on a regular follow-up, and she did really well, and the eyes remained dry throughout the 5. At 5 years follow-up, she presented with a sudden vision loss in the left eye. Her vision dropped to 20/80. On color fundus photographs, you can see subretinal hemorrhage. On OCT, there is a reactivation of the CNV. However, if you look carefully on OCT angiography, you can see on the outer retinal slab, there is a type 1 network which is present at the deeper level, but there is a differential flow signal which is shown with the help of thick arrows, which we suspected to be a type 2 network, which is shown as a more hyperreflective signal on outer retinal slab. And this patient underwent 3 Zeltrop injection and she was put on Aptus. And here you can see that the fluid has completely resolved, and you can see that the type 1 network is still present. However, it is not active. If you compare with the pre-injection OCT angiography slabs, here you can see that the hyperreflective signal which was seen on outer retinal slab has completely resolved. However, the type 1 network which was present before is still persistent. This is how we use the OCT angiography in understanding the differential flow signal strength, which could actually explain the type 1 and type 2 CNV network. With this, I would conclude saying that OCT angio plays an important role in CSCR.
I particularly use it for feedback evaluation or CNV detection in complex situations. However, at the same time, we should be very careful about artifacts. Therefore, the multimodal imaging is very useful. The common question asked is that can it replace ICG angiography in this disease? I would say we are still uncertain. There is lots to learn as we move forward. With this, I would like to acknowledge LV Prasad Eye Institute, where I practiced in India. Thank you very much for your attention.
Thank you very much, Doctor. That was an amazing talk, and I would want you to stay on for the discussion, which is going to be done by Dr. Muralidhar.
Thank you, Jay. That was a wonderful presentation of the use of OCTA. And especially as I agree with you that the chief use of OCTA in chronic CSR is to detect CNVMs, which sometimes even on FFA or ICG or elusive. One of the things that often baffles me is, when there is an atrophy and then there is a choroidal vessels showing through that. Sometimes there could be a confusion regarding CNVM versus, the normal choroidal vessels, and sometimes we really, find it hard to distinguish. What are your tips on this? And secondly, you also showed a patient in which post PDT the type 2 CNVM remained the same, right?
Sorry, the type 1 CNV.
Type 1 CNVM did not change at all. Did you give any anti-VEGF in that situation?
No, so that was one of the interesting cases, I would say, that really taught me a lot, that OCT angio can still show you the network which may not be active. So that was the network which we were seeing almost for 5 years. And then she came in the clinic with the sudden vision loss, with the subretinal hemorrhage, which itself is very uncommon if you really think about type 1. But when we looked at the OCT angio, there was a differential signal on the OCT angio where you could see that the type 1 network, which was there for last 5 years, on top of that, there was a more hyper reflective, or I should say a higher signal on OCT angio. And that's where we could correlate it with the type 2 component. So I thought that this could be really a great use of OCT angio, where you are able to actually differentiate the signal strength from above and below the RPE. So, and we saw that as soon as we started her on anti-VEGF, not on PDT, but on anti-VEGF, as we know that the type 2 regresses very quickly. And that's what we saw in that case as well, where the type 2 component regressed after the injection, but the type 1 remained same as it was earlier. Anand had a question.
Yeah, Jay, again, fantastic presentation. Always wonderful to listen to you about, especially on CSCR. I just wanted to know, again, with that same case with restricted with Zaltrap, given that experience, when you have a CNV that you, CSR that you feel has regressed or is stable, and you have this network lying quiescent there, do you actually follow up this regularly and look for those pruning small vessels like the way we try to do in MNV, AMD MNV cases? You actually try to look back and see if there's an increase in those small little pruning vessels.
Yeah, absolutely right. And I think that is where we all have to understand that OCT angio, particularly in CSCR, the way Dr. Muralidhar was mentioning, that because the inner choroidal vessel, inner choroid is really thin because of the pachychoroid, everything is pushed upwards. So it is possible that you may be able to see the vessels much more clearly and without any activity. So I think OCT angio will show you the vessels, but the more important thing is that whether those vessels are active or not, and then we can use some other signs such as a subretinal fluid, or if the FIPID is increasing in size, or you just mentioned look for the pruning of the vessels as we follow up with AMD cases. So it's like a double-edged sword.
Yeah, I think George sir wanted to make a point. Yeah, quickly.
Yeah, thanks, Jay. Once again, bringing this up, and OCT angio. Now, since even in chronic CSR, the pathophysiology have moved into inner choroidal choriocapillary ischemia, especially shown as, on OCT angio, overlying this huge pachy vessels which are compressive in nature. That's the first point that Jay mentioned. about the inner choroidal ischemia, that is low flow areas. Second thing, I do 100% agree with that for flat irregular PEDs, the problem with fluorescein angiography as well as ICG angiography to pick up this neovascularization, fluorescein will just show diffuse leakage because there will be diffuse RP epitheliopathy, and decompensated RP just shows up as late diffuse leakage. You cannot pick up these fine new vessels within the flat irregular PD. So I 100% agree, because OCT angio has a high sensitivity in picking up this subtle neovascularization, as Jay had shown beautifully here. And otherwise it will be missed in those situations. And it's very important for the retinologist to segment at the correct plane, because as Dr. Muralidhar was mentioning, that artifacts come, especially if you're looking at the various automated slabs. If you do a careful segmentation, I think we can pick up quite well.
Oh, thanks a lot for the great discussion which followed, and all the best to you for your OR today, Dr. Jay.
Thank you so much. Thanks a lot.
Having you over in more of our ARC programs. And we shall now go on to our next speaker, Dr. Mahesh Shanmugam, who heads the Vitreoretina and Ocular Oncology Services at Shankara Eye Hospitals, an extremely innovative, brilliant individual, and is also presently the Chairman Scientific Committee of ARSI. And I'm sure he's going to lead this society way forward in his term. And he is going to be talking on angiographic patterns in intraocular tumors. On to you, and the discussant here is Dr. Guru Prasad. On to you, Dr. Mahesh.
Thank you, Dr. Chitra, and thank you, Dr. Chitra and Srinivas, for inviting me to this wonderful session. So let's look at the angiographic patterns in intraocular tumors. So as in any other investigation, angiography is useful, but then it's not diagnostic as far as tumors are concerned. It may help differentiate one tumor from the other. And it's particularly useful in vascular tumors. And as I mentioned, it's not diagnostic. In retinal tumors, you would do an FFA. ICG may not play much of a role, but in choroidal tumors, FFA and an ICG can play a role. Opta can be used in both, but the issue is that it needs manual segmentation, as we will see subsequently. So let's start with the retinal vascular tumors. Retinal capillary hemangioblastoma, it's a clinical diagnosis. We will see this dilated retinal arteriole and the draining dilated venule, and a vascular tumor in between, which is orange red in color. And if you were to do a fundus fluorescein angiogram, this tumor fills very rapidly along with the arteriole. And because of a very high flow system, it kind of fills in very rapidly. The capillaries fill in rapidly, and profuse leakage is what you would see. So clinical diagnosis, what you would see as far as the capillary hemangioblastoma, capillary hemangioblastoma is concerned. But then what is the use of a fundus fluorescein angiogram? The advantage of a fundus fluorescein angiogram is it shows up these tiny new lesions which may not be picked up on clinical examination. Particularly in von Hippel-Lindau, the earlier you treat the disease, better is the outcome. So we pick up these small tumors and treat them at the earliest, then these eyes are likely to do well, but otherwise these eyes may be lost as the tumors continue to increase in size. So let's move on to the OCTA. Yes, OCTA can be done, and it shows the beautiful capillary network within the tumor. But the thing is, it doesn't show leakage. It's one way a good thing, because the vascularity within the tumor is seen quite well. And we can see the presence of the feeder arteriole and the draining venule. And once again, you can use the OCTA to pick up these very subtle tumors which are not obvious in clinical examination. Here we see a fundus photograph. You can see one lesion here, but this lesion here is not visible. But then when we do a OCTA, it is picked up quite easily. But what is the limitation? The white field octa is not freely available with most of us. And when the white field octa is freely available, then we can replace the fundus fluorescein angiogram with white field octa to pick up these very, very tiny tumors in von Hippel-Lindau disease so that we can treat them early. Here is one patient where there looks like a disc edema, and we are not very sure of the diagnosis. And we did an octa here, and you can see that there is a retinal feeder vessel here and a compact vascularity. So what we're seeing here is an endophytic juxtapapilar retinal capillary hemangioblastoma. So you can make a diagnosis just based on the octa here. Let's move on to another retinal tumor. This is a cavernous hemangioma. Cavernous hemangioma is like grape-like cluster of sacules which have a sluggish flow within. So what happens is the RBCs and the other white blood cells settle down within the sacules. That's what we see here, the dark red color. And the upper part is just plasma. And so when we do a fluorescent angiogram, this plasma alone fills, giving rise to this beautiful fluorescent caps. So these fluorescent caps are very, very diagnostic as far as cavernous hemangioma. And this kind of helps us diagnose in subtle cases, as in this case. This lady presented with a vitreous hemorrhage and a pre-retinal hemorrhage overlying the disc, and we could not see the underlying tumor. But when the hemorrhage cleared and when we did the fundus fluorescent angiogram, you can see these beautiful fluorescent caps, and this patient was treated with photodynamic therapy subsequently. Yet another vascular tumor involving the retina is a vasoproliferative tumor. This once again has vessels which are feeding a yellow-white tumor, usually situated in the inferior periphery. The vessels are not too dilated, but you can see the extensive exudation. And they do leak profusely, and a fundus fluorescent angiogram can help pick up these lesions as well. Retinoblastoma is another tumor where very rarely we can do a fundus fluorescent angiogram. The issue is because these are being children, you need a specialized equipment like the RedCam, which is capable of doing a fundus fluorescent angiography. And fundus fluorescent angiogram is not necessary for diagnosis or for treatment, but in subtle cases where there is recurrences along the scar, then this can be picked up by doing a fundus fluorescent angiogram, which can show up these areas as a vascular lesion, and an early recurrence at the edge of a scar can be picked up by doing the fundus fluorescent angiogram. And here we see a lesion which mimics retinoblastoma, but it's actually an astrocytic hamartoma. It is an octa, which shows there is no vascularity within. And similarly, the fundus fluorescent angiogram also does not show vascularity. So you can do FFA to differentiate retinoblastoma from an astrocytic hamartoma. Let's move on to choroidal tumors. This is a solitary choroidal hemangioma. Because it's connected to the choroidal circulation, it fills very rapidly in the choroidal space itself, and it's a vascular tumor, so it tends to leak profusely as well. So early hyperfluorescence, which increases in intensity, and pooling of the dye when there is a retinal detachment and leakage is what we see. ICG is very characteristic as far as choroidal hemangioma is concerned. So it fills within the first 1 minute here, and the hypocynosins, what happens is the dye tends to wash off because ICG is bound to the proteins. So it doesn't stay there, it tends to wash off. So at 20 minutes, the dye tends to wash off. So that's very classic of a choroidal hemangioma, which doesn't happen in a choroidal melanoma. So octa also shows up this network and shows that the network of the tumor is distinct from the surrounding choroidal vasculature. And here we see 3 different tumors, and we picked up this octa to be useful in kind of predicting which tumor is likely to leak and which tumor may not leak. You can see these black areas. You see the signal void areas. When the signal void areas are more, then these tumors probably do not leak much. So that's what we found. So octa can be used to predict which tumor is going to leak and which you would probably want to treat. So here is a patient who has probably a normal looking fundus, almost a normal looking fundus, but then the right side, there's a patient Port-Weinstein. And you see the octa, you can see this beautiful network of bag of worms, like appearance, which is distinct from the other choroidal vessels, thereby helping us make a diagnosis of a diffuse choroidal hemangioma. Moving on to choroidal melanoma, there is nothing specific about choroidal melanoma except for the fact that sometimes may show what we call as a double circulation. Double circulation is the simultaneous filling of the overlying retinal vessels, and the underlying tumor feeder vessels is called as the choroidal. It is called as the double circulation. Once again, the dye fills in very rapidly because it's connected to the choroidal circulation. But because of the lot of pigment in the tumor, the lot of the dye is masked. So you hardly see much of a fluorescein except for this spotty areas of fluorescein, which do leak in the late phase. And ICG, once again, shows that you can see the beautiful double circulation. You can see the choroidal vessel supplying the tumor out here, and tends to leak a little bit, but much less leakage than what you would see in a hemangioma. So you can do octa in these elevated tumors. The problem is when you do a machine-aided octa, this is how you'll get these images, because the machine tends not to look at the elevation of the tumor, so it's not able to segment and give us a beautiful picture of the vascularity of the tumor. But on the other hand, if you sit and modify the octa and manually segment, you can get these beautiful images. So elevated tumors like a melanoma, if you were to sit and segment them individually, then you can get much more information of the tumor vascularity. So here is one patient which has an elevated lesion here and another pigmented lesion which possibly looks like a melanoma. But if you were to do octa, you can see that this is vascularized. There is vascular network within. So this is actually a juxtapapillae melanoma. Here there's no vasculature at all, which is essentially a melanocytoma of the optic disc. So another utility of Octa is to help differentiate between melanoma and the nevus. You can see this is a melanoma. So melanoma has an ill-defined margin. In contrast, nevus has a sharply defined margin. And there is a hyporeflective choriocapillaries in melanoma, and the avascular areas are more in the melanoma, and choroidal vascular changes are also there in the melanoma. So any nevus which is converting to a melanoma, you can differentiate by using the Octa. Here is a 40-year-old lady who was referred as a melanoma, and you can see this spotty hyperfluorescence, which looks like very much like that of a melanoma. But then if you look at the disc, you can see a hot disc. So what you're looking at is not a melanoma, but an inflammatory pathology, which is essentially posterior scleritis, and you can see patient resolved after steroid therapy. Choroidal lymphoma, you can see this speckled hyperfluorescence, and if there is a vasculitis in a primary intraocular lymphoma, you can see a hot disc and vascular changes. But there's nothing peculiar about a choroidal lymphoma FFA. Osteoma, yes, a simple osteoma as such can show this pinpoint hyperfluorescence, but with minimal leak. But the utility of FFA is the identification of choroidal neovascular membrane in an osteoma. And Octa, yes, does do a great job of identifying this choroidal neovascular membranes associated with the osteoma, as you can see here. To summarize, angiography in tumors is not necessary for diagnosis, but then it may help differentiate a couple of tumors. And in retinal tumors, fluorescent angiogram Octa can identify small tumors missed on clinical examination, particularly vascular tumors of the retina. It helps confirm the diagnosis. Choroidal tumors, it identifies complications such as choroidal neovascular membrane in the choroidal osteoma. And it can aid differentiate hemangioma from a melanoma, nevus from a melanoma, and neoplastic from an inflammatory pathology. Thank you very much.
Thanks again, Dr. Mahesh. That was a wonderful talk, like hearing a story about tumors. And on to you, Doctor.
Yeah, thank you, Dr. Mahesh. That was a treat to hear, as always. And there's nothing to discuss in this. Once you have said everything, I think there's nothing that can be added by anybody. However, for the purpose of discussion and for the benefit of audience, I think we will just generate some discussion about this. You did mention about the role of angiography in the retinal capillary hemangioblastoma or hemangiomas. And you said that Octa also is helpful, but at the moment, I think with the limitations that we have in Octa, that we don't have the wide field Octa, I think it is better to go with fluorescent angiogram to pick up these small lesions that you mentioned, which are useful to be diagnosed on an angiogram for the purpose of treatment at an early stage. And I want to know whether would you really like to treat these small lesions at that stage itself, or would you like to wait for them to become more obvious and treat them later? Because the bigger tumors are anyway quite obvious and overt, and we can treat them. The smaller tumors, can we wait for them to become overt in the absence of, if you don't want to do an angiogram?
I prefer to, thank you, Dr. Guruprasad, and thank you, Dr. Chitra, for the kind words. I prefer to treat these tumors as small as, at the earliest stage itself, because VHL, over the years, I found that VHL to be one of the most blinding diseases. So VHL can make a young patient blind in both the eyes very, very soon. So this may be the better eye. So I would prefer to treat the tumors when it can be treated with a simple laser photocoagulation. Once it becomes about 2 disc diameters, even the field of vision treatment becomes difficult. And we have this vitreoretinal form of the angioma where the vitreous tends to stick to it and then starts to pull the tumor up. So that causes a retinal detachment and becomes very difficult to manage. So those tumors are very difficult to do laser also. So when it is on the surface of the retina, when it is small, when we can directly laser photocoagulate, so that is why I would prefer to treat them, particularly in the VHL tumor.
Okay. Thank you, Dr. Mahesh. About the disc tumor that you mentioned, the example of a disc tumor which actually turned out to be some vascular tumor at the disc. Is it possible to distinguish between a real tumor, and just telangiectatic vessels because of disc edema? On the Octa.
Yeah. Octa, as I mentioned, once it is a little bit lifted, then we need to do some amount of manual segmentation. Otherwise, there is a possibility of losing the information. And these are usually lifted. The peripapillary hemangioblastomas are usually lifted, in contrast to only the vessels which are not lifted. So there'll be some amount of elevation, and it's not a disc edema in the sense the whole margin of the disc is not elevated, only one part is elevated. So that gives us a clue. And most of the time, it can be associated with the peripapillary exudation. It could be hard exudates, which make us look at it much more carefully, and subretinal fluid. So it is possible, the fact that it is elevated and also the fact that the network is different. You can see a feeder vessel also. So that helps us differentiate.
Srinivas, you have anything to
Yeah,
add?
sir, a very nice talk as usual. Sir, one thing is when it comes to the von Hippel-Lindau's disease, according to the Cambridge protocol for the screening of the patients, they have very nicely mentioned that the frequency of tumor is usually at the age around 25 to 60%. And these are the tumors, ACH, where we get the first most common presentation is in the eye, as compared to the spinal cord or the brain stem or the cerebellar or the pancreas or various other organs. So they also advise, yearly annual screening for FFA. And as you showed those beautiful pictures where you can just identify even the smallest lesions. So how practical is it to do annually in India? Because they say that anywhere from 10 years to 60 years. So, or should we wait for it to clinically get it, or how do you do the screening part in these cases, sir?
Yeah, practically speaking, now what I do is, like, if there's a family history, yes, of course, they come across. And most of the time, to make a diagnosis of VHL, you don't really need to do an FFA because you can do a genetic analysis right now. So with the genetic analysis and a chromosome 3, most of the time you can make a diagnosis of VHL, particularly if there's a family history. So that's what I would resort to first rather than doing an FFA every time. But the FFA would help us identify the tumors and treat. So to make a diagnosis of VHL, I would not be doing FFA in the current scenario.
Last point, Anand, sir.
Yeah, just a smaller, again, a wonderful presentation, Dr. Mahesh. Always a pleasure to listen to you. One little experience I'd like to share where I found FFA ICG especially useful. Like you mentioned, it's only angiography is probably useful only about half the time in tumors. Is in avelanotic melanomas, where I found that a couple of cases that I saw some time back had corkscrew vessels on the ICG. And this is one thing which I found, is great in diagnosing this. And it's also more importantly useful in differentiating it from metastasis, which that also could appear. So that's just a little point that I just like to share. And if you have any experiences with that.
Yeah, thanks, Dr. Anand. I agree to that. And I look at the metastasis on, if you were to do an ICG, will not have vasculature within. But in contrast, as you said, very rightly said, the melanoma does have vessels. Actually, the melanoma vascularity has a prognostic value also. I didn't go into it because I want to keep it basic for the postgraduates. So the vascular patterns have a prognostic potential as well. So that also can be studied. And like even on the OCTA, if you segment it properly, we can get to see these vascular patterns as well.
Thank you very much, Doctor. So do stay on with us for more interesting discussion forward. And we have our next speaker, our eminent Dr. Mahesh Gopalakrishnan, who's a senior consultant vitreoretinal retina service and the head of the department of the vitreoretinal retina services from Giridhar Eye Institute, Kochi. Again, a highly respected surgeon nationally and in the state of Kerala. And he is going to be talking on another very important topic, PCV angiographic discussion. On to you.
Thank you, madam. I'm audible now?
Yes, yes.
Yeah. So I will be talking on the angiographic patterns of PCV, mainly ICG angiography, because fluorescent angiography does not have much of role in diagnosis of PCV. And OCTA I have not taken because I thought this was a basic course. So in fact, PCV was coined by Yanusi in 1984 when I was in my school. So after 40 years also, we are having that term, and even though it has been modified, redefined by a lot of people, which included branching choroidal vascular network as well as polyp. And the location also has been found to be in the macula or peripapillary or periphery. So there are some changes in the polypoid choroidal vasculopathy epidemiology and types, but the basics remains the same. And it has network of vessels, polypoidal structures, and PED overlaying the polypoidal structure. So this is the basic thing in a PCV presentation. So it is supposed to be more in females in Europeans, but in India we see more males also. And clinical presentations vary. Subretinal hemorrhages in a hemorrhagic type. Then exudative type is there, where a lot of exudations are there. Then serosanguinous, you can see a tinge of blood also. And here the orange lesion is there, polyp, serosanguinous type. Then mixed type, exudates, hemorrhage, everything together. So these are all different types of PCV clinical presentations. So ICG angiography can demonstrate, this is the gold standard in diagnosis of PCV. It can demonstrate small cluster of numerous hyperfluorescent dots. Polyp can be large aneurysmal dilatation, grape-like clusters, and large vessel deformations can be there. So these are some of the examples. This is one of the early camera-based ICG where we can see in the, even if there is blood, you can see a string of polyp and a bunch of polyp in the just next to the fovea, infratemporal to the fovea. So polyp can be clearly demonstrated even with the in the presence of small hemorrhages. It can be subfoveal, where our treatment is little more difficult, but extrafoveal and peripapillary are amenable to thermal laser even with very good results. So, and I'll show you some of the examples. This is the bunch of polyps you can see in the temporal at the edge of the hemorrhages here. And this is late phase of ICG angiogram. This is another one, the peripapillary. Even clinically, you can see that orange lesion where there is a bunch of polyp in ICG. In many times, when there is a large subretinal hemorrhage, sub-RP hemorrhage, at the notch of the PED, you may be able to see a bunch of network of polyp. So this is peripapillary polyp, just above the disc, very common presentation. And sometimes it can be seen at the edge of the pigmentoepithelial detachment. So this is one difference of ICG hotspot compared to the RAP, where the hyperfluorescent spot is at the center in RAP, but here it is at the edge at the notch. So it is very useful. ICG is very useful in post-treatment, post-thermal laser. Here you can see the initial picture, pre-treatment polyp in the just extrafoveal, juxtafoveal area, and post-treatment the ICG shows disappearance of the polyp. So that is very useful in, this is another case, peripapillary polyp. And after injection and thermal laser, the exudate have disappeared, and even the ICG follow-up shows that disappearance of polyp. Another one, it looks like tributary vein occlusion, but FFA is not very conclusive, but you can see in ICG string of polyps. So this is another one. You can see light that polyp in multiple areas in the center of the exudates. So these are some of the cases. Initially, you can see this patient had a serous detachment, even though there was a polyp. Initially, anti-VEGF was tried, but there was no response. So 2014, 15, 16, and in spite of all these injections, polyps were not going. And after switching to photodynamic therapy, the polyp disappeared. So the angiographic closure is very important in many of these cases where you can it is more with photodynamic therapy. So this is another case where there is a serosanguinous detachment with polyp. After injections, we did the ICG again, and it showed a bunch of polyp, cluster of polyps, and then after doing the PDT, you can see the ICG complete disappearance of the cluster of polyp. So this and later after 2 years it started recurring, the branching started recurring. So this is after 2 years the branching vascular network is again the tip of the areas are coming and activated to new polyp. So repeat photodynamic therapy was done, and after that you can see again that bunch of polyp has disappeared. So the PDT should, when you do PDT, even though it is not available now, it should treat both polyp and branching vascular network. And BVN can be identified by double layer sign in OCT and OCTA. I am not discussing that area. And recurrence is very common in PCV after many years with new polyps and the worsening of branching vascular network. So this is another case where there is a bunch of polyp with double layer sign and the thumb-shaped PEDs. And later, the new polyps can appear. some of the examples I will show you. This is a case where the right eye is having pachychoroid spectrum, where the right eye is having leakage like a PCV. I mean, leakage like a central serous retinopathy, but no polyp is seen. But in the left eye, you can see the above the in the nasal part of the macula, you can see a bunch of polyp here in this area, and you can get in one eye PCV and the other eye central serous chorioretinopathy in many of these pachy spectrum. So this was another case. Right eye is already a scar. Left eye had a CSR-like leak in fluorescein angiogram way back in 2010. And later, after 5 years, patient developed a subretinal hemorrhage. At that time, there was a polyp at the subfoveal region.
You have 1 minute remaining, sir.
Yeah. So this is after treatment, there was disappearance. And patient had later, after many years, again recurrence of the polyp. So at that time, anti-VEGF injection was. So this is another patient. My old patient actually initially had a photodynamic therapy. That vascular network is recurring inferiorly and they later superiorly over many 8 years. You can see the angiography 2010, 13, 14, and the recurrence of polyp can be seen beautifully in angiography. The other aspect is peripheral polyp. In many of this is we can document this peripheral polyp by wide field angiography. Many cases where there is a hemorrhagic choroidal detachment in the periphery, you can get this peripheral polyp in ICG. The treatment depends on the involvement of macula and other factors. So sometimes it is thermal laser is possible in this area. So this is a peripheral polyp in you can the angiography, ICG angiography, you can see the bunch of polyp. So another this is just I'm finishing. A ring of polyp around a branching vascular network and post-treatment resolution. So this is pulsatile polyp. In fact, you can see that area. There's a nice pulsatile polyp. I have a collection of around 5-6 cases. We treat just like any other polyp, and we are not seen any massive hemorrhage in these cases. So even though the ICG angiography is not necessary to diagnose a polypoidal choroidal vasculopathy, and many of the OCT biomarkers can be useful in detecting PCV. ICG is the gold standard for diagnosis of PCV, and polyp and BVN are very important. And it is ICG demonstrates the post-treatment picture very useful. It is very useful in the management. OCT biomarkers are equally good, but for PDT and thermal laser, ICG is mandatory. Thank you for the kind attention.
Thank you very much for a very detailed talk, Dr. Mahesh. And has Dr. Moona Binde joined us?
Yeah. From Moona, madam. Yes, madam.
Yes. Thank you, Mahesh. That was a very nice demonstration of the ICG changes in PCV. Probably, I would request you to explain to the audience how often you would repeat an ICG, since you've confined your only to ICG. How often would you repeat an ICG? And in the post-PDT, we are, I think, now considering ourselves as the post-PDT era, where we know the BVN does not disappear with our anti-VEGF treatment. What are the ICG features that tell you that, yes, the patient is responding?
Yes, madam. Actually, we try to do ICG in all AMD PCV suspect cases initially. And post-treatment, if we are the ICG is most useful if you do a thermal laser or photodynamic therapy, where you can aim where to give the laser. So that is many cases extrafoveal polypendal, they respond beautifully with thermal laser. So I try to do ICG in all cases initially, and then if you want to see the response to treatment and you want to, thermal laser or PDT, I repeat ICG after 3 months. But in this anti-VEGF era, now we don't have PDT. So only if I suspect a peripapillary or extrafoveal polyp, I am doing ICG regularly.
And we also need to remember that the BVN would persist, and when we do focal treatment, very often we treat only the polyp.
Yes.
May find that some other tip of the BVN may leak at a later date. So it's important to delineate the entire extent of the lesion.
Yes, madam. That's what one case I showed. In 3 areas it came, and for over 10 years.
Yeah. And another point, probably you did show it in some of your cases. One of the patients, the choroidal circulation looked fairly okay, other than the PCV net. Whereas in another one, there was a lot of leaky choroid. We saw the dilated choroidal vessels.
Yeah.
Did see some amount of choroidal hyperpermeability. So what tips would you give to people if they were to identify this, and which phases of the ICG would you be looking for?
Yes, madam. Actually, the polyp and branching vascular network, the polyp will start little, not at the early phase like a RAP, where the hyperfluorescent spot is seen in a very early phase. So here, the mid phase is more useful to identify the branching vascular network and polyp. I think.
And we'd be also looking for, if you do, even if you don't have access to wide angled ICG, if you do an all quadrant ICG, you may see the dilated vortex veins. And in the late phase, you may see the leaky choroidal vessels, indicating that these are patients probably belonging to the pachychoroid spectrum. Would either George or Anand want to make a comment? This very nice talk.
Thank you, Dr. Mahesh, for a nice talk and covering ICG. I just want to add that you already brought in the point that this ICG mimickers of PCV also, because we talk about first 1 minute appearance of the hypercyanescent nodule with a halo of hypocyanescence, and along with BVM, that is a classic, and first 6 minutes of ICG angiography as a diagnostic sign for polypoidal lesion on ICG. But we have to keep in mind 2 or 3 mimickers of PCV, polypoidal hyperfluorescent nodule on ICG. One being RAP lesion, which you have already mentioned, which happens on the center of the PED and also appears in type 3 CNVM overlying the PED. Second, that also can produce submacular hemorrhage. Another would be a aneurysm, can produce submacular bleed or associated with intraretinal, subretinal or preretinal hemorrhage. So that also, the angiography is very important, both fluorescein and ICG, to pick up the lesion, diagnosis of RAM. Another is when you have concomitant microaneurysms of diabetic retinopathy, should not be confused for a CNVM, which might nodular microaneurysms may appear as small nodular hypercyanescent lesions, even on ICG. So these are what I would like to add. And to what Dr. Muna Madam has added, now since there is a trend of non-ICGA diagnostic modalities, and we are treating with only with anti-VEGF therapies like brolucizumab or aflibercept, it's very important to keep in mind that the polyp inactivation happens on OCT, but it's good to see whether the polyp is still active or not, because if you have pulsatile polyp, they may just present with large submacular bleed if you take it for granted that polyps have regressed based on the OCT signs. So this is what I would like to add to this.
Yeah. Just to add to what George and Dr. Muna said, one little more masquerader would be a choroidal knuckle, which I think George has painstakingly elaborated long back in the past. So that's another thing that that's a rare entity, but that is there for sure. And yes, as you know, we've seen over the last maybe few years, there is this trend, and APOIS, the Asia Pacific Ocular Imaging Society, has also highlighted the non-ICG characteristics. We've heard Dr. Jemmy Chung in various fora talk about how they are now relying in, and their sensitivity specificity seems to be high with these non-OIS, non-ICG criteria. Basically, sub-RP ring structures, the sharp tip TEV, and I think that RP elevation which they see. So I think that is that. How, I know you're reliant on ICG, but are you also in your practice now tending to move towards this more progressively, especially as Dr. Muna mentioned on follow, where we would not want to do too much of invasive angiography?
I think paucity of time, we are going to move on because we have a whole lot of speakers ahead. And I would want just the main discussant and maybe just one expert panel to take on each, because the others would be left way behind. We have our next speaker, Dr. Chitranjan Mishra, who is a medical consultant, retina and vitreous services from Arvind Eye Care Systems based at Madurai. And he is going to take us on to our next interesting talk, unmasking posterior uveitis with angiography. On to you, Dr. Chitranjan.
Thank you, madam. Are my slides visible, madam?
Yes, yes, yes.
So thank you, AIOS team, AIOS Chitra madam. My topic is stromal choroiditis, the angiography pictures. So based on angiography, we have divided choroiditis into choriocapillaritis and stromal choroiditis. The former one, the choriocapillaritis, is identified by irregular geographic hypofluorescent areas, as you can see over here in this left side panel. And the right side, we can see the stromal choroiditis, which is my topic. And here you can see the hypofluorescent dark dots, SDDs. So the former one will be discussed by Dr. Srinivas, and this stromal choroiditis is by me. Coming to the chapter proper, the stromal choroiditis. Again, it is divided into primary stromal choroiditis and secondary stromal choroiditis. Primary stromal choroiditis includes VK, sympathetic ophthalmia, and Bart's-Sett retinochoroiditis. Secondary includes tuberculosis and sarcoidosis. So why primary choroiditis? Because in primary stromal choroiditis, the focus of the disease entity is at the stroma, and other involvements start secondary to it. So what are the angiographic modalities? We have ICG, FFA, and OCTA. One line about FFA versus ICG for the sake of our residents and fellows who are attending. So in fluorescein, we can see the retinal structures very clearly. However, ICG is very, very important for the choroidal structure. Why? Because of the macromolecular size. One is the macromolecular size for which the diffusion occurs, the physiological diffusion occurs to the choriocapillaries only, and from the main vessel trunk it does not diffuse. And another thing is the 830 nanometer near infrared spectrum of light through which we can see the choroidal structures, and that's why FFA is having a little lesser importance, and FFA has limited role to evaluate choroid only in certain conditions, like during the initial 40 to 60 seconds of FFA, or if there is a window defect due to RPE damage, or there is in chorioretinal atrophy. So by and large, ICGA gives much more information in comparison to FFA. So what are the ICG angiographic signs of stromal choroiditis? Number one is SDD, or hypofluorescent dark dots. If you can see over here, hypofluorescent dark dots. Second one is indistinct or fuzzy choroidal vessels. As you can see over here, indistinct fuzzy choroidal vessels. Third one is the diffuse late choroidal hyperfluorescence, which almost hides the hypofluorescent dark dots that were seen in the intermediate phases. And also you can see a disc hyperfluorescence if it is a severe choroiditis picture. So coming to the first disease entity, that is VK syndrome, in which there is thickening of the choroidal stroma. And the primary insult is that the stromal melanocytes, adjacent damage is secondary to it. In ICG acute phase, we can get hypofluorescent dark dots in the intermediate phases, and usually accompanied by the other angiography features as I have described in the previous slide, and it regresses with treatment. Coming to FFA, the typical description starry sky pattern. Also, you can get the pooling if there is a neurosensory detachment. Disc hyperfluorescence both in acute and chronic phases can be found, and typically there is absence of retinal vasculitis. And in chronic phases, we can get multiple window defects. Coming to a case example, a 32-year-old male, we can see over here, this panel is the right eye, and the right side of the panel is the left eye. We can see the left panel is for the FFA, and the right panel is for the ICG. Early, intermediate, and late phases, as you can see over here, we can see nicely the hypofluorescent dark dots in the ICG. And in the FFA, we can get the typical starry sky pattern because of the pinpoint hyperfluorescence. And the disc hyperfluorescence also you can appreciate easily. Similar pictures are present in the left eye as well. Coming to another typical picture of VKs, the starry sky pattern, for the sake of the fellows and residents who are attending this one, a typical starry sky pattern, and also you can get a neurosensory detachment is present, that is identified by the pulling of the dye. The left eye also shows similar picture. Coming to sympathetic ophthalmia, almost similar to VKs. However, the difference between them is the history of trauma or surgery. and 90% of the diseases occur within 1 year. However, late presentation has also been reported. So as I have mentioned, the primary insult is at the stromal melanocytes and the adjacent damage follows. The typical ICG and FFA pictures are essentially almost same as VKs. So coming to an example, 45-year female, history of trauma, one eye is thicycle. After 1 month, patient is presenting with features of loss of vision, loss of accommodations like mild pain is there. Fundoscopy, you can get there is a neurosensor, there is a kind of serous elevation is there, and disc margin is blurred. Ultrasound B scan, you can see RCS thickening is there. There is exudative RD is there, and there is RC. There is kind of RP lumpy bumpy elevation is there. There is neurosensory detachment and subretinal fluid in the OCT. And coming to the angiography, FF, we can see there is disc hyperfluorescence. There is hypofluorescence corresponding to the area of detachment, and multiple pinpoint hyperfluorescence leaks are there. In ICG, we can see hypofluorescence dots are there. And in the late phase, we can get diffuse hyperfluorescence. Coming to another interesting picture of a case of bilateral retinochoroidal coloboma along with optic disc pit maculopathy. You can see in the OCT optic disc pit maculopathy. What we will do? VR surgery. Okay, vitreoretinal surgery was done, and the patient, fortunately, after 1 month, retina was almost flat. Optic pit, disc pit maculopathy resolved. However, after 1 month of that, patient presented with bilateral loss of vision, and B scan, if you can see, there is a kind of RCS thickening is there. And in OCT, the lower panel, you can see there is typical pictures of subretinal fluid is there, and bilateral presentation. Patient was diagnosed with sympathetic ophthalmia, bilateral. Fundoscopy, if you can see, there is a neurosensory detachment, and you can see small elevations in the posterior pole. FFA was done. You can see there is hyperfluorescent pinpoint leaks are there over here in bilaterally, and you can see the pooling of the dye corresponding to the area of the detachment. So patient was managed with immunosuppressives, and fortunately after 15 days of institution of therapy, patient responded very nicely, and both eyes macula almost became flat. Coming to Bardet retinochoroiditis, almost non-existent in India. That's why it's very obvious that I have borrowed all these cases or images from pre-internet sources. In Bardet choroiditis, the vitreous strands and vasculitis can be there. Vasculitis we can very well appreciate over here, and vitreous strands are there. In ICG, the hypofluorescent dots are there, and with treatment, they tend to vanish. Coming to TB, which is unfortunately very common in India. Coming to the FF features of TB, if there is a granuloma present, or if there is serpiginous choroiditis is there, initial hypo lesion will be there, and late it becomes hyperfluorescence. If there is neovascularization, we'll get hyperfluorescence. Capillary non-perfusion areas, if they are present, we can appreciate them, and disc hyperfluorescence can be found. In ICG, if there is a TB granuloma is there, we'll get hypofluorescence. And if serpiginous choroiditis is there, central inactive area may be hyperfluorescent, and the periphery active area may be hyperfluorescent. Coming to a typical example, we can appreciate over here, there is a granuloma, TB granuloma sitting over here. In the ICG early phases, we can get hypofluorescence.
You have 1 minute remaining, sir.
Yes. Late phases, it becomes hyperfluorescent. Left eye, we can get neovascularization and CNP areas, capillary non-perfusion areas. In the follow-up visits, patient has started with ATT and steroids. We can get hyperfluorescent corresponding to the granuloma, and left eye laser was done for the CNP areas and NVE, and subsequently patient developed CNVM in the right eye. We can appreciate over here in the OCT. Coming to the OCTA, we can get tangled meshwork of the vessels in the OCTA, and in the optic disc area, we can get engorgement of the vessels. Left eye was essentially normal. So after the anti-VEGF injections were given, we can see in the follow-up visits the rarefaction of the vessels. That means the density of the tangled mesh of the vessels decreased. Other features in OCTA we can get, that is flow wide area or presence of a neovascular area, we can get it in OCTA. Coming to ICG of TB granuloma, again, I have taken it from a nice article in AIOS, American Journal. You can get the granuloma is there, and corresponding hypofluorescent area is there. Serpiginous choroiditis needs a mention. So this is again another nice article from AIOS. In the central inactive area, we can appreciate, and the periphery, the area is active. In FF, we can get central, there is kind of window defect kind of stain. On periphery, you can get there is a fluorescent area because of the staining. And ICG also central hypofluorescent. In the late phases also central hypofluorescent. However, periphery may show slightly hyperfluorescent area. Coming to sarcoid, the typical example is the typical differentiation from the TB is that we'll get multiple discrete small granulomas in comparison to TB where it is larger granuloma. So coming to ICGA, in the early and intermediate phases, we can get hypofluorescent areas which tend to vanish in the later phases. Okay. This is one example of a case of left eye CNVM. Patient was given anti-VEGF injections. It was refractory. However, on cursory examination, we can see there are multiple granulomas, multiple choroidal granulomas are there. And the FFA was done. You can nicely find out over here, there is a hyperfluorescence, slightly hyperfluorescent area, and patient was worked up, ACE was elevated, subpleural nodule was there, patient was diagnosed to be sarcoid granuloma, started on immunosuppressives, plus anti-VEGF injections, and this time the patient responded very nicely, final vision almost 6/6 parts. Coming to a line of differentiation between ICGA of tubercular versus sarcoid granuloma, the one line of differentiation from a very beautiful article in American Journal, if you can find out, TB is a solitary large granuloma. However, sarcoid, we get multiple small granulomas. Okay. So coming to the summary of the angiography of stromal choroiditis, hypofluorescent dark dots on ICGA is very typical. Starry sky appearance in VKs and SO are very typical, that is described. Solitary granuloma in TB and multiple smaller granulomas in sarcoid. OCT is gaining popularity because of its non-invasiveness. And however, multimodal imaging and clinical diagnosis remains very, very crucial towards the diagnosis. I must thank team AIOS ARC Srinivasa Chitra Madam, and also to all my colleagues and my teachers who have helped me in this PPT. Thank you.
Wonderful, thorough talk, Dr. Chitranjan, and really good, and look forward to some discussion from Dr. Anand.
Thank you, madam.
That was terrific, Chitranjan. Chitranjan's been a very young, energetic colleague of mine from my time in Madurai. It's wonderful to hear him give this excellent talk. So, I mean, I think he's covered everything. I just want to highlight a few things. One, he started off with talking about VKH. And in that, like the textbook teaching is that the starry sky is seen. And when it is seen, it's usually classical. But one must almost also remember that it's not universal. It's classical, but it's not universal. So you may be disappointed in not seeing it. So it really typifies the pinpoint RP leaks. That is the starry sky lighting up in the acute phase. Also, specifically about ICG, because there's a lot of interest in ICG in choroidal disease, especially stromal choroidal disease. You get that hypo senescence converting to hyper in the acute stages. But once the disease crosses over into the convalescent stage, for example, you get these diffuse pigmentary marked, plaques there, and therefore you get a hyposenescence which persists all through. One question allied to this is, now in this last couple of years, we've been seeing a lot of, surprisingly, post-COVID as well as post-vaccine inflammatory stromal choroiditis. And we've reported few of cases of VKH, cases similar. So the pattern, the classical pattern is somewhat different in these situations. Apart from that, I also want to highlight that, the role of FFI-ICG in this generally in stromal choroidal disease is also highlighted more when you have inflammatory CNVMs, as you pointed out in your presentation. I think that is one place where, when a disease crosses over to its chronic stage and then incites a choroidal neovascular stage, that is where also there is an additional use for FFA-ICG. Third thing I'd also like to highlight is that, we, in the first part of this symposium, we looked at CSER, and we didn't really touch upon fluorescein angiography ICG in CSER. I think the commonest differential and one of the commonest reasons for referencing CSER is choroiditis or inflammatory. And the reason why people confuse CSER for stromal choroiditis is because of subretinal fibrin, which exists in CSER. And what happens there is the classic inkblot leak that gets distorted by the underlying fibrin, which in turn looks like choroiditis. I just want to highlight this over and above what Chitranjan has beautifully presented. So,
yes. Srinivas, you want to add anything?
I think Muna madam, we can bring in up here. Muna madam, are you there?
Yeah, I'm there. I just wanted Dr. Mishra to just tell us, because the differential usually is for a solitary TB granuloma, but we know you can get miliary tubercles as well, which are multiple, as opposed similar to sarcoid. So, do you have any clues to differentiate those?
Like here, probably what I think we have to take the other history also, like tubercular history and maybe Mantoux test and other features suggestive of TB, because as you have already rightly told, clinically these lesions may be indistinguishable, biliary TB and sarcoid granuloma, because both will be solitary, multiple and all. So there, the other ancillary investigations, history, other things will help. That is what I think others, maybe seniors, will guide.
Yes. Yes. So I think
Mona
we
madam
can
wants
want-
to comment on this quickly.
I think probably you would have to use the OCT to help to differentiate, because tubercular are usually a little more superficial than these sarcoid granulomas. So that would possibly be one of the clues. But excellent talk, Dr. Mishra. I really enjoyed it, especially the surprise of the optic pit.
Thank you, ma'am. Thank you. This was actually, ODP was operated by our HOD sir, Dr. Naresh sir, and managed both in retina and UVA departments of our hospital. Fortunately, patient did very well. As you see, the macula is entirely flat after 15 days of the starting of the immunosuppressives.
So we shall now go on to our next speaker, Dr. Srinivas Joshi, who's going to be talking on the other aspect, choriocapillaritis. On to you, Srinivas.
Yeah, good evening, everyone. At the outset, I would like to thank Team ARC and Chitra Madam for arranging this wonderful discussion and the webinar. So as Dr. Chitranjan has covered the most of the things, I just want to bring it to the notice here that we all know that the dye goes into these choroidal vessels and then they try to leak out. So we need to know that the ICG, as he described, has around 700 and odd Daltons of the molecular weight. But when it comes to ICG with protein complex, then it becomes quite heavier, around 50,000 to around 80,000 Daltons. So that is why I think ICG is most preferred in these kinds of either the choriocapillaritis or in cases of the stromal choroiditis. The another advantage is, you have these fenestrations in the choriocapillaries, and probably that is the reason for the filling of the choriocapillaries and causing the choroidal fluorescence. But however, if we see the retinal vessels, they are tight junctions, they are impermeable. So the leakage of the sodium fluorescein shows that the vessel is inflamed. So here I just want to bring up another slide which differentiates between the two, where I divided this topic as the stromal as well as the choriocapillaritis. In the choriocapillaritis basically happens in the choriocapillaris level, and the non-perfusion is basically due to the loss of the choriocapillaries. And here, but in case of stromal choroiditis, because there is no filling of the dye into the stroma, I think this causes the blockage. And because the dye doesn't flow into this space, and because of these inflammatory lesions, and that is when we get more commonly the hypocyanocytic or the hypofluorescent areas. So coming to the inflammatory choriocapillaritis, you can see here, these inflammatory choriocapillaritis are basically the geographical areas where you can see they are pretty much irregular type 1 geographical area of hypocyanocytes. And Dr. Chitranjan has nicely described choriocapillaritis. We describe into the primary, where he described of the stromal. So I'll be describing about the primary is basically where we have this mutes, AMPI, or we have the multifocal choroiditis or the serpiginous choroiditis. And the secondary could be due to any other infections like the TB or due to the syphilitic causes. In the stromal choroiditis, he has nicely explained it is mainly because of the HDDs, and these HDDs are round, numerous, and they are evenly distributed. But however, in cases of stromal choroiditis, we see after the treatment, the good sign is these fuzzy indistinct choroidal vessels, which we are not able to see in this slide. So after the initiation of the IV steroid therapy, you can delineate these choroidal vessels again very distinctly. And you can see these HDDs, what were there, have been partially resolved. So stromal choroiditis, he has explained it. It could be a primary or the secondary due to infectious causes. Octa also is a very important tool. It's not only used for the superficial or the deep vascular plexus, but definitely we also use it in the choriocapillaris as well as in the choroidal area to know the choriocapillaris void areas, that is flow void areas. So this is how you can see this is the case where you have the hypocyanocytes here in this case. And definitely you can see the corresponding OCTA in this. If you look into it, there's definitely a choriocapillaris flow void area, which definitely indicates that this could be a case of AMPI. So in this, if you can see here, this is another case, 18-year-old female, diminution of vision in the right eye, few paracentral scotomas and a decreased field of view. The patient although had 6/6 parts vision, but patient was symptomatic, and you can see some yellowish lesions here, although it's not very seen very nicely over the clinical pictures. But when we did the FAF, I think FAF is another interesting modality, and you can see there is a hyper-autofluorescence in these areas when this corresponding to the angiography, which is not showing any much in case of fluorescein angiography. And definitely, if you can correspond it to the OCT, you can see some areas where there is loss of the outer retinal layers. And even in this area, you can see there is a loss of the outer retinal layers. So the patient was, since it was symptomatic, the patient was started on steroids. Then after 2 weeks, we can see the FAF, how nicely it's trying to resolve. And definitely, this is almost a result. The patient had 6/6 vision and was not very, is basically asymptomatic. So basically, it's the mutes where we have the young myopic women. They usually have flu-like symptoms. It's usually unilateral. The patient present with subjective scotomas, photopsia, diminution of vision. And the earlier faint discolored, 100 to 200 microns has been described along the temporal arcades or the posterior pole or the mid periphery. They resolve well. But however, when we see these kind of picture, there's basically a granularity. So this granularity is what makes that this patient had a mutes before and is now improving. So this is again the OCT and ICG and FFA. You can see here the hyposinusant area here, which is increasing in the late phases, and also corresponding FAF. You can see this areas of hyperfluorescence is there, which shows that progressing of the disease. So in mutes, we see ICG is hypo early, hypo late. In OCT, there is loss of photoreceptor outer segment. But however, in AF, we can see hyperfluorescence, this exposure of RP lipofusion following the loss of the outer outer photoreceptor segment. So this is the another case where you can see yellowish white areas here. You can see here some hypopigmented areas. And definitely when we do the ICG, you can definitely see these kind of hyposinusant areas. There is on OCT is also an NSD there. And in the late frames of the ICG, these lesions are very well delineated. They are clear. And again, FAF can definitely show the hyperfluorescence areas here, which tells us that there is a disease activity. And after initiation of treatment, now you can see definitely there was good improvement and the NSD was resolved. So these are the case of AMPI, where we see most commonly in the young myopic woman. One eye may be affected first, and the subjective scotomas, photopsia, and diminution of vision is probably based on the location. So in case of AMPI, also follows the same rule, that is early hypo, late hypo. OCT shows the loss of photoreceptor, and FAF shows that there is hyper FAF, but hypo in cases where there is atrophic lesion due to the previous episodes. The associated CNS involvement is very important in case of AMPI, especially when the patient presents with headache and have mimicked the migraine with kind of aura. So another thing, just the last two things I want to cover is the PIC or the multifocal choroiditis. They are usually, the characteristics are lesions tends to leave the scar, that is a numerous scar randomly distributed, recurrent behavior of the disease, and the propensity to develop secondary neovascular membrane are more common in cases of these diseases. And again, you can see these hyposinusant small areas which are getting more delineated in the later frames of the ICG. But if you see the FFA here, you can see the pooling. It's basically the reactionary kind of hyperpermeability of these vessels where we see the pooling in cases of FFA, as contrast to ICG where we can see the more of the hyposinusance in those areas. So this is again a FAF picture which shows the progression, and after the treatment we see there is a complete resolution. And if you look into the 10 degree of visual field perimetry, you can see these areas corresponding to these, they show kind of scotomas. But again, after the initiation of treatment, you see the less of these hyposinusant areas, and definitely, although very few areas are there, there are very less scotomas as recorded in the visual fields. So the last one is the serpiginous choroiditis. It's the most severe end of the spectrum, progressive, recurrent, and usually the patient are elderly with scotomas and the metamorphopsia. Here, the importance I wanted to make here, the difference between the FA and ICG is, although FFA shows hyperfluorescence, but the correct delineation of what is the exact lesion of this scar is definitely shown better with ICGA as compared to the fundus fluorescein picture here. And definitely you can see there is a kind of hypersinusance surrounding this area, which shows that there is a disease activity. So the delineation of these kind of scars or the disease progressive is much better in case of ICGA as compared to the fundus picture alone or in cases of FFA. So this was the last case. I just wanted to show the patient already presented with this picture, and this was the picture when they presented. The patient had 612 vision, and this is the FAF picture where it shows a lot of hypoautofluorescent areas, already scarred up areas. And here, along with the hypoautofluorescence, we see some hyperautofluorescent areas, which shows that the disease is progressing. So this is basically a kind of relentless kind of serpiginous choroidopathies which keep on moving. So this require a very rapid kind of IV steroid treatment. And if it is associated with Montus or like serpiginous-like choroidopathy, I think it is always better to add AKT also along with the pulse steroid and the oral steroid. So here, in spite of adding these, you can see the relentless disease progression in these kind of SLC-like cases. So lastly, I would like to conclude with this slide that in case of mutes, there is a regular involvement of the end capillary vessels, which are reversible. But in case of AMPI, there is involvement of the precapillary arterioles, which are again reversible. However, in cases, if you see MFC and serpiginous, it is the irregular involvement of the precapillary arterioles and as well as the larger arterioles. And because of the onset, the subset of the disease, it's usually irreversible. And the response to the treatment is basically how early we start and how hard we hit on these kind of cases. So just I would like to end up telling that the choriocapillaris inflammation, we saw it as the mutes, AMPI, multifocal choroidal serpiginous. And in case of stromal, it has been nicely described by Dr. Chitranjan, where we have primary obligatory stromal choroiditis, where we explain about the VKH, sympathetic, and the birdshot. And in the location of the systemic disease, definitely the sarcoidosis and the tuberculosis and the syphilis is what falls into the classification. With the interest of time, I would like to thank Department of Vitreoretina and my dear fellow, Dr. Rohan Dediya, for helping me in this presentation. Thank you very much for allowing me to present these cases.
Yes, a very wonderful talk, Srinivas. Nothing less was expected from you. So we look forward to Dr. George for the discussion.
Thanks, Srinivas, for covering the inner choroidal inflammations, choriocapillaritis. So in this, as you have beautifully shown, basically the inflammation involves the inner choroid and RP level. So there are some diseases which are very widespread and severe, like as you said, serpiginous choroiditis and multifocal choroiditis. But there are subtle diseases which one could miss actually. So I would just to stress upon these diseases, which almost, one thing is the level of the lesion. Some of them are outer retina, some of them are RP and choriocapillary lesions. For example, what you showed, the mutes, almost normal clinical picture. So I think we have to be aware that patient has subtle symptoms, but then it is very important to have a fundus autofluorescence, fluorescein angiography, and ICG angiography, which shows so much of findings in these mute patients. For autofluorescence, as you showed, hyperautofluorescence, but normal looking fundus almost. And hypo on ICG, hypocyanescence on ICG, and the wreath-like around the arcade, wreath-like granular hyperfluorescence. These are all classics of mutes. So mutes, basically, we know that it's an outer choroid, like outer nuclear layer and the ISOS junction, ellipsoid zone. That is where the inflammation happens. And as you have rightly mentioned, in the other entities like APM, PP, you have the RP and choriocapillary inflammation, and that produces this hypo on ICG. And as you rightly mentioned, the precapillary arterioles are narrowed and there is a less leakage because of the inflammation, less leakage from the capillary level. That is why we are getting this hypo on ICG and things. So rightly said. So two more entities just to bring in, because they also look almost normal fundus on top of what you have added. One is RP epitheliitis, and next is acute idiopathic maculopathy. unilateral acute idiopathic maculopathy, they also have inflammation at the level of RP and the outer retina, showing ellipsoid zone hyperreflectivity, loss of ellipsoid zone in both these conditions. Wherein RP epitheliitis, classic finding is this granular pigmented cluster of granular lesions at the fovea, and in acute idiopathic maculopathy, you have this yellowish, whitish gray outer retinal lesion with the thickening of the RP. So it's very important to differentiate these from what Chittaranjan had mentioned, the outer choroidal inflammation. So these entities are very important, and fluorescent angiography, ICG, and fundus autofluorescence, as you have nicely demonstrated, has to be done in these patients to differentiate these entities.
Thank you very much, Dr. George, for summarizing it so well. Anybody has to add anything, or shall we move on to our next speaker? Anybody on the expert panel? I think it's been well covered. So we shall now go on to our next speaker, Dr. Tapas Ranjan, who's a consultant vitreoretina services from LV Prasad Eye Institute based at Bhubaneswar. And he is going to be telling us about the utilities of red-free imaging in vascular retinopathies. On to you. And we will be having Dr. Muralidhar doing the discussion.
Good evening and greetings, and thanks for giving me an opportunity to share this simple yet useful technique, and that I use it frequently. So can you, are my slides visible?
Yes.
So evaluation of the superficial retinal blood vessels can be done in various ways, ranging from color fundus imaging, optical coherence tomography, angiography, fundus fluorescein angiogram, red-free fundus imaging. Now, fundus fluorescein angiogram, in addition to showing the blood vessels, it gives an idea on the dynamic properties of the blood vessels, which we usually don't get in other modalities. However, it has its limitations that all of us know. It's an invasive.
Dr. Tapas, your slides are not moving. You are not on slideshow.
Can you see it now? Is it moving?
No, it's not moving.
So
maybe we'll have to go slide by slide.
Maybe I will stop share and reshare again.
Yeah.
Can you see it now?
Yes.
Yes.
Yeah,
That's right.
So this being invasive, so we think twice before ordering it. There are, of course, contraindications, and the dye-related allergy, though rare, still they do exist. And of course, time consuming, we can't repeat it every visit if we want to follow up these patients with vascular retinopathies. Red-free fundus imaging is non-invasive, cheap, and the superficial retinal layers and the blood vessels stand out with excellent contrast. Say, for example, this one image taken with JS450, the fundus photo that has been montaged. We can see the various lesions here. Now, if we do it in the red-free, we can see that the images become more prominent, the lesions become more prominent, especially all the cottonwool spots, the retinal hemorrhages, the exudates, the vascular lesions. Now, I realized that what I do, we usually stop here. Now, the moment if we zoom these images, then you start seeing much more lesions that we see in the fundus photography as well as in the indirect ophthalmoscope. Now, this is an image, that cropped image from Optos, and it has been magnified, and we see that here it is 100% red, and we see that the lesions, as we keep on decreasing the red component and increase the green component, we see that the blood vessels become more and more prominent, and the vascular lesions are more apparent. You can see a neovascular front here, and if we make it again green, and here red 0, green 100%, we can see that there are numerous vascular lesions and probably capillary free areas here and a neovascular front here. So on zooming it out, say as per the requirement, if it is like I zoom it up to 300 three times, 300 to 400, then the number of lesions that I see clinically, here in red free, they appear more. Again, another example, the montage color fundus imaging, we can see that there is a sclerosclerous blood vessels. Now, corkscrew like the shunt blood vessels here, and communicating blood vessels from here to, from lower quadrant to the superior quadrant. And there are some lesions here which we are not sure what it is. And if we do the red-free imaging, you can see that the lesions are much more apparent, clearer. But again, to get a deeper look, one need to magnify. And if we magnify, we see that there is a neovascular font which is sitting right here, and then many more informations that we get from. Again, if you still magnify, you can see, oh my God, this one is running and compressing on this blood vessel. So we get better information with this red-free imaging, and still better if we magnify it. So there are hardly few literature on the utility of red-free imaging compared to the color fundus imaging vis-a-vis fundus fluorescein angiogram. These, for example, this group of this study from a study published in International Ophthalmology in 2012 showed that detection of most of the diabetic retinopathy lesions are better with red-free imaging than with color fundus imaging. The red-free images revealed NVD and NV more often than color fundus imaging. This one by Chitra Jayadev et al. Utility of non-invasive imaging modalities in a retina practice, they showed that neovascularization and CNP areas, the detection rate is with red-free imaging is comparable to FFA. This one again a novel non-invasive detection method for retinal non-perfusion using confocal red-free imaging. They show that the plotting efficacy of non-perfused retina, like the retina free of devoid of blood supply, appear dark and featureless, and this the plotting can be as close as fundus fluorescein angiogram. So with this, I had a question that how do they really help in the clinic? So we took up this study, efficacy of red-free imaging versus clinical color fundus imaging in detecting various retinal vascular lesions with FFA's gold standard. So 1.5 year study. So what we did at that time, we didn't have the wide field fundus cameras. So we used montaged color fundus image and with montaged red-free images, and the images were distributed to 3 retina specialists. They looked at the images at 3 different points of time, and FFA was taken as the gold standard for confirmation. 80 subjects, 129 eyes, had an DR followed by vascular occlusion, followed by vasculitis. Now the analysis was done with respect to the type, number, and extent of various retinal pathology, the diagnostic accuracy, the time taken to detect these lesions. So what we got it that in the detection rate of any lesion overall, the total confirmed lesions were much more, almost more than 2 to 3 times than the color fundus imaging. And we can see that in all neovascular, NBE, NBD, collateral, IRME, in all these lesions, the red-free had a higher score. This is and most important, the average time to detect individual lesions were much less with red-free imaging than the color fundus imaging. So if an image is given to us, a montaged red-free image, the time taken to detect various vascular lesions is much more less than the color fundus imaging. Now, the key points that we get here is the detection of neovascularization elsewhere, NBD, IRMA, collateral, sclerosed blood vessels. The rate and accuracy of red-free imaging is much more than color fundus imaging. Now, sometimes during clinical, in the busy clinic, during clinical examination, when we look at the fundus images and detect the pathologies, write down our notes. If we quiz ourselves and see all the cases, take the fundus images and see that whether did we miss any lesion, you will find that many times we do miss some of the lesions that gets picked up by the images. The time taken to detect an individual retinal vascular lesion with red-free imaging is less than color fundus imaging. Now the qualitative the result that we got, the lesion morphology, the relationship of the lesion, vascular lesion with the surrounding structures are better with RFI. The montage red-free images can give a good and quick panoramic view of the entire retina at a glance, and help in making sure that I'm not missing any important retinal vascular pathologies. Helpful in a busy clinic when FFA is contraindicated or can't be repeated for multiple times. Magnified images in a bigger screen, the detection rate of vascular anomalies are better with either modalities. Still, RFI is better than C5.
We have 1 minute remaining, sir.
Yeah, I'll finish this case for 1 minute. This is a baby, 27-week gestational age, birth weight 700 gram. He came to us at 37 weeks of post-menstrual age, almost 10 weeks after the baby should have come earlier, and was from an ICU where the oxygen was given for 30 days. You can see there are arcading and shunting, and the media was hazy. This is the right eye, and the left eye. And again, the blood vessels, the numerous arteriovenous shunts at multiple level, and there is a corkscrew shunt almost running all around. So I wanted, if we want to analyze is better, again, some red-free, though we don't have a filter in those cameras, but we can do some red-free enhancement and get a better idea. The baby was too sick for laser, so intravitreal anti-VEGF was given, and we can see the baby. After that, the parents lost to follow for 1 year, and they just came. You can see this the image taken with 1 year baby with optos and the fundus image, and the corresponding red-free magnified. If we see carefully, we can see that there is a neovascular font here. There is some sort of regressed fibrovascular polyp here, and the blood vessels they stop here. So now these avascular retina and the neovascular font is now enough for me to decide I'm going to treat this baby. I'm not going to leave it if I don't have an angiogram. So again, this is the left eye nasal quadrant. You can see that this is the color fundus image, and the red-free image. This is the new vascular font, again vascular avascular junction. But fortunately we had a angiogram available. We can see that this is avascular retina, and confluent in the leak here and leakage from here, right eye and left eye. Finally, laser was done to this avascular retina, as is shown here. So, though definitely fundus fluorescein angiogram gives us a better insight and with more confidence. But if we don't have these gadgets available, or doing it is an issue, red-free imaging do give us enough idea or adequate idea to take a decision on this treatment and follow. I thank you all again, and stay here and conclude my talk.
Thank you very much, Doctor. That was a wonderful talk, and we look forward to Dr. Muralidhar's discussions.
Wonderful talk, Tapas. You actually, now I'm quite happy to see that some of the things which used to exist before, are being rediscovered now, and more and more uses are being put. I remember, when we had the direct ophthalmoscope. I mean, we still have them, but I don't use them anymore. But it had a green filter, and we used to use that quite often, earlier also. And the green red-free filter, again, of course, is not pertaining to retina. And now fiber layer analysis again became prominent with the red-free light. Tapas, with the in the glaucoma field, the now fiber layer analysis with the red-free light was quite practiced. But now the retinal surgeons are discovering the red-free light more and more with the newer imaging modalities. One question I wanted to ask you, Tapas, what happens to the choroid lesions when you use the green light?
So these lesions are they are not prominent in green light. The choroidal lesions become prominent as we increase the spectrum and use.
Yeah, that way the red and the green are opposite. If you want to see the choroid lesions, you shoot the red image. And if you want to see using the green image, the choroidal lesions tend to get hidden almost. The almost choroid becomes invisible. That's a very interesting phenomena. I use red-free filter in my clinical practice, especially when we are seeing a patient with severe NPDR looking for IRMAS, new vessel. Sometimes my fellow says it's a new vessel. Then whether it's a new vessel or a hemorrhage, there is a debate, and we tend to actually use the red free light at that time and see these lesions much better. I agree with you. It's a very useful tool, but my own doubt is that we are not using it as much as we should be using it. I would love to hear from others. I have started using it more now, and I would love to hear from others, what their experience is. I think it's a wonderful tool which is underused.
Yeah, we can have comment from the other panelists. Yeah. Okay, Guru sir.
Yeah, I personally feel that red-free imaging was definitely, like Murli said, we used to use it in the past to see the nerve fiber layer and the hemorrhages and the superficial structures which images. Maybe for the ERMs as well. Apart from the retinal structures, the epiretinal membranes also used to be better delineated with the red-free light. But I think in the present day, in the era of high resolution SLO-based imaging, I think we should resort more to multicolor imaging than to just red-free. Red-free has its own limitations. Like Murli said, the choroid is totally cut off. So we are more interested in deeper and deeper structures nowadays. So we should, I think, go for multicolor imaging if we have the facility, and try to image the RP and the choroid, because red-free imaging alone has its own limitations. With the multicolor imaging, we can actually see the CNVMs, the PCVs, along with the superficial structures. So I think we should have had a topic on multicolor imaging rather than just red-free, considering that we are in 2022.
Yes, I agree. I think red-free is great for your superficial retinal pathology, especially vitreoretinal interface pathologies. And I think you mentioned that multicolor imaging comes. It's a great tool to look at all three layers, all three depths of imaging. But I would reserve it for VR interface.
Basically, red-free is for retina. Retinal vascular lesions it's really good and really helpful. Yeah.
Sir, what NSM sir and Guru sir was telling, is there any, because of the improvement in the technology, and now we have the superluminescent diode kind of lasers, which we use in the OCTs and in the Heidelberg system. So does it make the lesions, as Tapas sir was telling, the lesions delineating more better than what we used to have before? And that is why he is bringing it again, telling it that when we see his comparison between the color fundus photograph and the red-free images using the SLO-based devices, he has showed somewhere around 70 to 80% kind of detection as compared to the 30 to 40% on the clinical-based imaging. So does this SLO-based is adding more this thing to that, or I just wanted to know?
I think it is SLO-based technology that is adding more in terms of resolution, and not the flash-based imaging devices that we used to use before. That is what is adding to the resolution than the actual technology or the wavelength. Because I think the nerve fiber layer, if you take the nerve fiber layer, which we were discussing about, me and Murli, I think there's a lot to gain from learning about what happens to the nerve fiber layer if there is a nitrogenic break during a diabetic vitrectomy or a drainage retinotomy close to the posterior pole. Beyond that, the nerve fiber layers tend to die, and as the closer you are to the disc, the larger the number of nerve fiber layers that can get affected, and this can be studied very well with SLO-based imaging rather than with flash-based imaging. So I think there's a lot to learn from that.
I think Muna madam wanted to make a comment. Yes, Muna madam, please.
Just a quick comment. Tapas, that was a very nice talk. Dr. Muralidhar, that sometimes a simple red-free photograph, which is available on any basic camera system, can confirm IRMA and new vessels. I think that's a cheap and effective way rather than getting a fluorescein angiogram or an OCT angiogram. I think we shouldn't ignore that use for it, even though we have advanced techniques. people think like new vessels.
Thank you. Thank you very much for the contributions. We shall now go on to our next speaker, Dr. Vishal Govindhari, who is again a vitreoretina consultant and also pediatric retinal services from LV Prasad, Hyderabad. And he's going to be talking on many phases of diabetic retinopathy using angiography. And we would have Dr. Guru Prasad as the discussant here.
Yeah, I hope my slides are visible and I'm audible.
Yes, Vishal, go ahead.
So I thank Chitra ma'am and Srinivas sir for this opportunity. Just a small correction, ma'am. I work at Pushpagiri Vitreoretina Institute, not at LV Prasad, Hyderabad.
Sorry. I'm very sorry.
No issues. So my talk today will be about many phases of diabetic retinopathy using angiography, and I'll be predominantly dealing with FFA and OCTA. So basically, angiography predominantly now has been divided into the use of dye-invasive fluorescent angiography and OCTA, which is non-invasive, dye-free. And there's obviously the new tool in the block, which is not new anymore, which is quite picking up quite quickly, which is the wide field angiography and the ultra-wide field angiography. One sort of definition is based on the number of degrees, while it covers with respect to wide field and ultra-wide field, whereas the consensus statement published by Dr. Sadda and group speaks about the area which it covers. That is up to the vortex mains, it's called wide field, and beyond that, it's called ultra-wide field. So we'll just get to why angiography at all in DR. The main function which we have with regards to angiography in DR, or the phase of DR, which we normally want to assess with the angiography now in today's world, is assessing macular ischemia and prognosticating visual acuity accordingly. Also, assessing the peripheral avascular retina has become a thing of importance, considering the role it plays not just in the development of CNPs and neovascular areas, but also in the role in recalcitrant DME, the targeted laser techniques which we're using today. Establishing proliferative diabetic retinopathy is something which is less often requiring angiography, and Dr. Tapas has beautifully shown how you don't need angiography, just a red-free can do it for you. Detection of some comorbid syndromes like OIS, where the arm to retina time in a dye-based angiography is really useful to sort of understand why a patient is, having sudden neovascularization of iris, for example, just in a case of PDR. We'll look at a few cases to start with. We have a 47-year-old female with a 4-year history of type 2 diabetes with a 6/9 vision in right eye and 6/36 in the left eye. Grading-wise, it was just a mild NPDR. The OCT seemed innocuous in the right eye, and the OCTA did have some amount of capillary separation in the deep capillary plexus, which is our main area of interest, because this is the one which supplies the inner retina and causes functional loss when there are changes. But when you look at the left eye OCT, it hardly shows any changes. But you look at the OCTA, there is huge area of avascular zone increase, and these small aneurysms and widening of the intercapillary spaces. This sort of has translated into a lot of ischemia. Traditionally, we would have done a fluorescent angiogram to understand this, but OCTA now has sort of helped us understand this much easier in a non-invasive way. And this sort of helps us, prognosticate and explain to the patient what is happening with him and how we need to sort of work on him systemically. Another case, 44-year-old male, type 2 diabetic with 6/24 vision in the right eye. No improvement further, and a clear lens in mild NPDR. We don't expect a 6/24 vision in these eyes, no CSME. Again, the OCT of the right eye looks very innocuous, barring this single microaneurysm, which my pointer is showing, which is seen in the OCT as well. But when you look at the OCTA, it's quite clearly showing the kind of pruning of the vessel margins with aneurysms and a very, very enlarged FAZ and increased intercapillary space. So this is sort of telling us why the 6/24 is happening here and what we have to sort of work with the patient. So these were two cases where OCTA very clearly diagnosed DMI. Now, clinically, though it is not relevant, a lot of indices which are coming in, like the vessel density or the intercapillary spacing or the fractal dimension, which tells us the complexity of the blood vessels, or the area of the foveal avascular zone, which we are routinely measuring. These are sort of measures which we do on angiography to assess DMI, more on OCTA to be specific. When you look at the significance, vessel density in superficial and deep capillary plexus are quite important for the diagnosis of DM. for DR, as well as just in patients with DM, it's a predictor of oncoming DR. Intercapillary spacing detects CNPs much earlier than vessel density and is much more sensitive. And the FAZ area has been a sort of a favorite with all of us with regards to understanding DR severity as well as functional loss. When it comes to the FFA, diabetic macular edema ischemia has been defined as a increase of FAZ more than 1,000 microns, which notched or bordered by microaneurysms, telangiectasias, and pruned arterioles. And this has a direct correlation not only to the functional loss, but also to the severity of DR. Moving on, we look at another case of a 47-year-old male with decent vision, 6'9" and 6'6", 3 years duration of history of type 2 diabetes and hypertension of 1 year duration. Both eyes have early lens changes. Fundus photo did have a few diabetic changes, but the angiogram was quite dramatic. This sort of angiogram we do see quite often. You see large capillary non-perfusion areas in the traditional FFA here. What is important to note is areas of leakage around the vessels. Apart from the NVEs and the CNP areas, you have these late vascular leakage which happens around the vessels. This is basically a sign of ischemia. You can see them in multiple areas along the vessel walls, all along the vessel walls and extending past the vessel walls as well. Notwithstanding the NVEs, these leakages are quite prominent in these eyes. And you have a diffuse leakage at the late phase along with an NVD at the posterior. The other eye had some similar findings with large CNP areas, multiple NVEs, and perivascular leakage. So when you look at these eyes, some important things which you have to know is late perivascular leakage is a marker of CNP area and development of further neovascularization. So in a patient who possibly does not have NVEs but is showing a lot of leakage, you would want to sort of look at treating these patients in case you don't have a good follow-up with them or they're not going to have good diabetic control. This intense ischemia was noted in the previous images, and the percentage of ischemia over the total retinal area is defined as the ischemic index. This has a direct bearing on not just the occurrence of DME, but also with the occurrence of recalcitrant DME, with the occurrence of comorbid coexisting macular ischemia and the severity of DR. So these sort of indices are quite useful for us to understand, based on simple angiography, what sort of diabetic phase or diabetic retinopathy phase the patient is in. Very interesting paper by Dhananjay Shukla sir and team, which speaks about featureless retina, where you see in the red fundus photo, and as very nicely shown by Tapas sir, the red free, you find these wiry white arterioles with very minimal findings of diabetic retinopathy and areas of thin retina. But when you do an FFA, you find quite a lot of CNP areas, you find capillary dropouts, capillary dropouts, you find NVEs, and you find macular ischemia in these cases. So as the description suggests, normally these are eyes where one eye has PDR and the other eye is diagnosed as a mild or moderate NPDR. So it leads to an asymmetric DR grading, but actually ends up being a featureless retina. This is an important finding which angiography can pick up. Whitefield angiography is picking up quite a bit. We have the Whitefield fluorescent angiogram as well as the Whitefield OCT angiogram coming in now. And here we can see that lots of areas which would have been traditionally missed by the traditional 50-degree angiograph, even with a montaging, is being picked up by one shot in the Whitefield. It is expensive and it is a challenge to image with these eyes, but obviously there is purchase with the kind of imaging it comes out. Very interesting fact that compared to 7-field angiography, Whitefield shows 3 times more retinal surface and a multi-fold increase in non-perfusion area and neovascularization. So the detection rates are much higher with Whitefield. Just pardon me, just 1 second. So these were a couple of papers where Mukit et al. Looked at Whitefield, using Whitefield angiography to sort of target their treatment. They looked at a Pascal laser, full threshold laser versus a reduced fluence laser, and they did selective areas of treatment predominantly based on Whitefield, and this led to much better responses with regards to development of reduced development of secondary macular edema or worsening of macular edema, which we can see with traditional laser systems. The regression of PDR was similar with both these systems, and this sort of helped us to understand that even in these phases of diabetic retinopathy where you do have lasered eye, but still there is peripheral ischemia, Whitefield imaging angiography can be very, very useful. To conclude, angiography of any sort, dye or non-dye base, is essential in picking up very subtle presentations of DR, such as macular ischemia and featureless retina. And use of various modalities, such as the Whitefield opta, help tailoring treatments and prognosticating the various stages of DR. I'd like to acknowledge Dr. Srinivas Joshi and his fellow Rohan for helping me with the images, as well as my fellow Amrita. Thank you so much for the opportunity, and I'm open to any questions or comments.
That was a wonderful presentation, Dr. Vishal. I mean, very, very detailed. And yes, we look forward to the discussion now. Yes, Dr. Guru.
Nice, Dr. Vishal. Thank you for that nice presentation. Just a couple of points, maybe 3 points in all, I have just noted down during your talk. Number one, I'll go from last to first. You said featureless retina. I think one of the cases you showed featureless retina. I just want to share my case. Just about 3 days ago, I had a patient with NVI in a diabetic patient, and I found that the fundus was totally normal. In fact, clinically normal disc, normal vessels, and no, not a single dot hemorrhage or a microaneurysm, even on 90-day examination or the optos. So I thought we will go for a carotid Doppler test because these patients are, also vulnerable for major artery occlusive disease. So we thought we'll do a carotid Doppler to find out whether NVI is caused by carotid artery occlusive disease. But the carotid turned out to be normal, and then we resorted to FFA. And on FFA, we found that the featureless retina, the so-called featureless retina, was actually studded with multiple leaks right from the disc to the periphery, a lot of CNP areas. So featureless retina is something that you should first investigate with FFA. That was a lesson I learned. Then later carotid Doppler. So this is something which I just wanted to convey. And about the macular ischemia that you mentioned in a patient with 624 with widened avascular, foveal avascular zone. I think they always don't go hand in hand. Sometimes we have good vision in spite of a capillary dropout in the peripheral capillary network. They always don't go hand in hand, and therefore one should also look at the disc, maybe the structural OCT and also the disc in these patients, because they always have some coexisting ischemic optic neuropathy as well. And therefore, we should not just say macular ischemia in all these cases causing the loss of vision. About recalcitrant DME, there was an article by Paul Tournambe long ago. The title of the article was "Macular Edema is a Peripheral Disease." So I think that is something which was very catchy, but I don't know whether we can resort to TRP to control recalcitrant DME. I want to know the experience of the entire panel here. I personally have not had good results with treating or tightening a PRP. We don't have access to more than 102 degrees of angiography, not more than what the Heidelberg can give us. But if wide angle angiography means more than 102, then I think tightening is good enough. Tightening the PRP is good enough to cover up the the untreated areas, and that doesn't really result in treatment or cure of a recalcitrant DME. I just want to know the opinion of the panel. Yeah.
I mean, I agree with you. A very interesting and attractive proposition that peripheral ischemia, if it is more, it gives rise to more VEGF production and macular edema. But I don't think it's ever been proven, although it's a very attractive hypothesis. And we have studies, especially in vein occlusions, where a peripheral ablation has not really changed the macular edema much. So, although it remains an attractive hypothesis, but not really proven. So, I don't really go ahead and do peripheral PRP for recalcitrant macular edema. Either it's diabetic or a vein occlusion. I've stopped doing that.
Right.
Yes, I think I've also had just mixed success. I think when you're talking recalcitrant DME, it's more other factors, non-VEGF factors, which are probably in play, rather than burning out everything. So I also agree with Dr. says. I haven't had, but there are anecdotal reports in literature where they've shown success.
But there are cases.
There
Those
are
studies
reports.
have
There
not
are
shown
studies,
unequivocally. It has not been shown that peripheral laser is. But there are cases, especially before you shift to a steroid in a phakic clear lens patient. It would be a good idea to do a wide field angio and do a targeted PRP if it shows significant areas of capillary non-perfusion. In such cases, it might help, not in all cases, as Dr. Guru Prasad said.
Good. That's a good discussion. So we shall go on to our next speaker, Dr. Ashay Naika, who is a vitreoretina consultant from the Eye Foundation group of hospital, a very dynamic, highly charged, energetic, and also an innovative person he is. And it's been always a pleasure to work with him. And he would be talking on ultra wide field relevance in vascular occlusions and vasculitis. And Dr. Muna Bede would be discussing this.
At the outset, thank you, ma'am. Thank you, Chitra, ma'am, and Srinivas, sir, for providing me this wonderful opportunity. This presentation itself was quite a learning experience for me to look at this technique. So I'll be talking on ultra-wide field angiography relevance in vascular occlusion and vasculitis. I have no financial disclosures. So it is very evident that with the more pathology we decipher, in ultra-wide field, we get a lot of information where it makes us to arrive at more informed decisions to tackle our regular cases in vein occlusions. So the pertinent question which we were discussing previously is there a need to look beyond the posterior pole in retinal vein occlusions? So the main impact of ultra-wide field would be in studying this peripheral non-perfusion area, especially its effect on the risk of neovascularization and also its effect on macular edema. So this is a case of BRVO who had 6/6 vision. But on the angiography, we could see this large ischemic areas. So earlier with BO study, we knew that more than 5 disc areas would be ischemic BRVO. What I have done is taken the small disc size circle and fitted with the similar circles all around where there was capillary non-perfusion area. I could fit more than 50 disc areas. So this, as of now, there is no paper which says what is the risk of neovascularization. But this paper by Lepp et al. Showed that if the disc areas is in the range of 5 to 354, with a median being 114, with a standard deviation of 80, all can give a risk of neovascularization. So, however, it doesn't make a concrete, give us a concrete definite number of what area is having more risk of neovascularization in BRVO. But it certainly gives 3 new angiographic patterns called the 3 Bs. That is the black retinal ischemia, which is seen in 100% of these cases, and the small budding retinal microvascular anomalies, and which is also seen in 100% of cases, and in at least 40% cases, which is associated with MVA at the border. So these 3 recurring patterns are also seen in, is been described by this paper. Another case where patient had large areas of retinal ischemia. Here also I have just tried to see how much I can fit disc areas, and I could easily fit around 120 disc areas. So the older definition of 10 disc diameters of non-perfusion is almost irrelevant now. And with ultra wide field, it is very makes us easy to identify the CNP areas in a better way. And as we all know, less than 30 disc areas has low risk for neovascularization, and more than 75 disc areas has high risk for neovascularization. This paper by Nicholson et al. Showed that there is zero risk of neovascularization, zero in patients with 10 disc areas, and around 20% with 30 to 75 disc areas, and more than 80% in about 75 to 150 disc areas. But the most important point in this paper was about talking its relationship with the peripheral neovascular non-perfusion area and the posterior pole non-perfusion area. If the isolated non-perfusion area is more than 10 disc areas in the periphery, it had a very low disc area, very low risk of developing neovascularization. But if it was more than 10 disc areas of non-perfusion in the posterior pole itself, the risk was more than 85% for developing neovascularization. So this is very evidently given in these two examples. See in this paper, in this example, the area is much less than the example 2, but since the posterior pole is involved, there is neovascularization. So with ultra-wide field angiography, the posterior pole non-perfusion of more than 10 disc area remains the key risk factor for the development of neovascularization. And another important indicator is ischemic index, which Su et al. Described and showed that it has a significant correlation with neovascularization, and eyes that had evidence of neovascularization had more than 45%. So, however, as we were previously discussing with targeted retinal photocoagulation, only Tomoyamatsu et al. Showed that it can reduce the amount of recurrent edema in BRVO. But this paper by Vinod Kumar et al. Showed that with ultra-wide field, we can actually identify the neovascular area, which is, in this case, it has already been lasered, and by doing a targeted retinal laser, the patient was treated very adequately. So this case, again, as was previously discussed, try to answer this significant question, that is whether a targeted retinal perfusion in the peripheral area, especially in ischemic CRVO, where patients were incomplete responders to previous anti-VEGF therapy, does that targeted retinal photocoagulation help to reduce the edema? But the answer was the role of targeted retinal photocoagulation was not did not have a conclusive benefit to reduce the burden of treatment of recalcitrant macular edema, and the severity of macular edema correlated well with the ischemic index of the entire retina and the perimacular area, and the reduction in macular area was correlated with the reduction in ischemic index of the entire retina, as well as the ischemic index of the near peripheral area and the perimacular area. So this case this paper by Nicholson et al. Also showed that as the with ultra-wide field angiography, it was correlated that more than 10 disc areas of the posterior pole of retinal capillary non-perfusion was associated with large peripheral non-perfusion area. And the risk of anterior segment neovascularization is not abolished by using concomitant anti-VEGF therapy. So primarily, they say if the posterior pole disc area of more than 10 disc areas are there, then the peripheral ischemia will also be significant and can also cause anterior segment neovascularization. And the fellow eye also is very important, because this paper showed 11% involvement of when the fellow eye with peripheral vascular leakage, which was associated due to hypertension or higher load of inflammatory markers, inflammatory cells, and as well as undiagnosed bilaterality. So ultra-wide field octa is also is coming of age, but it doesn't give, other than showing the microaneurysms, retinal microvascular abnormalities, it doesn't add much to the treatment. In coming to vasculitis, ultra-wide field has a great advantage because it helps in identifying the disease activity, which will help in changing management. And this is very evident by this paper, where it showed that only with examination disease activity was seen in around 38%, but with ultra wide field imaging they were able to see the activity in almost 67.6%. So this paper by NP Jones identified almost 58% of their patients with which was there outside this 7 8 EDRS fields, and 20% of the patients were purely treated on the basis of ultra wide field imaging. This is a case where with SLE who had 20/20 vision, and the posterior pole had not much activity, but with ultra wide field the peripheral areas had phlebitis, and it is outside the 7 field of ETDRS chart. So this is another case which had absolutely normal vision with SLE vasculitis, and on peripheral examination, there was a neovascularization. The patient was already treated with laser, and more laser was added to manage this case. So this paper by Vinod Kumar et al. Used ultra-wide field imaging in Eales disease, and which they concluded that it was helpful in documentation of peripheral retinal changes in 60% of their eyes, and the exact location of capillary non-perfusion was seen made out in 54% of the eyes, and
You have 1 minute remaining, sir.
And in determination of vascular network in 21% of the eyes. So in 30% of the eyes, they were able to revise the treatment immediately. In this patient already lasered, there was neovascularization, they immediately lasered, and the neovascularizations quietened down. This paper by Chaudhary et al. In 2019 came with a consensus about wide field imaging, and based on the Optos gives around 200 degrees, but now with this they based it on the anatomical landmarks, and also told wide field images can be montaged to create ultra wide field view. Basically, the information is already there. Ultra wide field will give us in a single picture, and not many of us have an access to this wonderful tool which can be used in our daily practice. So how can we achieve ultra wide field in our daily practice is something which all my friends keep asking, and to give it an answer, I suggest we should all use this new open source software called AutoStitch. People who are interested can download from this link. And this is one paper where with this software, these 8 pictures were seamlessly stitched to give a wide field imaging, and it can be used. It does not give you a very large Mercator projection artifact, which is already seen in other montage softwares, and it's absolutely free, and everyone can use it, and everyone can use the magic of ultra wide field imaging to treat their patients. Thank you.
Very good, excellent talk, Dr. Ashray, and very well covered, and we look forward to the discussion. Dr. Muna.
Yeah, thank you, Ashray. That was a very nice talk. And I think you covered most of the applications of ultra-wide field imaging in vasculitis and vein occlusions. We all agree that it's quite contentious whether we would treat macular edema based on what ischemia you see in the periphery. But I would agree that ultra-wide field is important when you have patients where you think you have treated adequately. Patient is having rubeosis, repeated rebleeds. So those situations definitely it helps, especially in a patient with a CRV. A little clue or a warning when we rely only on ultra wide field, especially in cases with vasculitis. Sometimes we tend to miss finer points of the disc and the posterior pole because we are so interested in the periphery. I would suggest that magnify it. If you're using a Heidelberg, take a couple of 30-degree views somewhere in the middle of the angiogram so that you know that you're not missing neovascularization of the disc and thinking it is disc leak, because I have known that to happen. Whereas with the new California Optos, you can magnify any picture and it doesn't lose its resolution. So I think that's just 2 points that I thought I would tell you that we can use. And Heidelberg has the auto montage facility, so you can get, you needn't use an external software.
Thank you very much, Dr. Muna. We shall now go on to our next speaker, Dr. Anand Vinekar, who's a professor and head of the Department of the Pediatric Retinal Services at Narayan Nethralaya Eye Institute, and is been the founder, program director of this amazing ROP program, which he had initiated, and probably one of the largest in the world. And he is going to be telling us about bringing order to pediatric vascular diseases. So on to you, Dr. Anand.
Thank you, Chitra ma'am, and thank you, Srinivas and the AIOC ARC committee for this opportunity. I'm going to be talking about angiography in infants and pediatric cases. So, well, there are currently 2 devices that can be used. One is the RedCam 3. that is really not portable. So one has to keep it in the institute, so we don't really move it out. And the other one, which is just now commercially available, is the same Forus Trinetra Neo, which has now come up with a FFA module. This was during the clinical trial where we had actually taken it into an NICU where we have used it. So it's a little more portable. But the process and everything else remains the same. 10% sodium fluorescein, some people have used 20%. That's the dosage, 0.077 ml per kg. This is the Baskin-Palmer regime that was published over 3 decades ago. Test dose is not really mandated. Of course, you must have an IV cannula and a resuscitation equipment. Either the neonatologist or the pediatrician should be around, and keep the baby for observation and tell them the post-procedure instructions. I've really structured this entire talk into just cases without much theory for our younger audience. So first I'll deal with the non-ROP type of entities and then ROP. So this one you'd really mistake for ROP because it's no different actually. But when you realize the term vitreopathy, a part of FEVR, and you look at that leakage in the middle panel lower in the angiogram, that leakage which is actually coming from at the interface between the vitreous body and the retina. And of course, we know that this is FEVR because subsequently this child was proven to be genetically proven, but otherwise could have easily been mistaken. Falciform folds then give you a sort of indication that this could move towards FEVR, and this is the same child in one eye and a falciform fold, and in the other eye, very innocuous looking stage which can be picked up on angiogram. So the idea is FEVR is unilateral only in about 15% of cases, and angiogram helps us decide, especially in these asymmetric cases, when to do the treatment. Now, obvious cases of coats or coats-like reaction, you see exudation, you think coats in a male child with one eye, really important to rule out other entities that mimic this, right from retinoblastoma, FEVR itself, PFVS, noris, and so on. The lighted bulb appearance, which is so commonly spoken about in coats, is not as commonly seen. Of course, in the periphery, you can see telangiectasias only in the earlier phases. In the later phases, it all looks like a diffuse leak. But the whole idea is to pick up the ischemic areas so that you can target the treatment, either with anti-VEGF, with laser, cryo, or even surgery, depending on how severe the condition is. Now, this is a condition, incontinentia pigmenta, is not as uncommon in India as thought out to be. It's an X-linked dominant condition. And you see these pigmentations, often the diagnosis is made by a dermatologist or a pediatrician. And if you're lucky, then you see neovascularization and you have the ability to do the treatment. Often, unfortunately, these babies come with already advanced retinal detachments, sometimes in one eye, and therefore you need to make a diagnosis. And this is where angiography, showing you the neovascularization, and here on the OCT, the NV as well, then we can make a very selected treatment. Noris disease, again thought to be not so common in India, but the key word here to remember Noris is dysplasia. So an aplastic or a dysplastic looking retina, where there are hardly any features of what looks like a retina, which otherwise would mimic FEVR, is therefore Noris. And of course, genetics would be the only way to prove it. And this neovascularization and the ischemia is extremely intense. It's very gross, and usually what looks like a very bad NVD or a very small amount of retina that is viable around the disc. I've clubbed a few conditions here, hematomas and other syndromes. So this ash leaf spot, if we care to look at the rest of the body of the child which comes with an eye problem, you can pick up many of these conditions who present with seizures and cortical vision impairment when they actually have tuberous sclerosis. What I want to show you here is the mismatch between what an OCT can pick up and the angiogram picks up. When the surface of this hematoma is really irregular, the smaller capillaries are going to be leaking the dye, and that's how it's picked up, maybe as a stain, maybe as a leak, as you see in this lesion. In another lesion, which is so easily picked up both clinically and on OCT, it's not lighting up on the angiogram. Smooth surface, no choriocapillaries, no capillaries on the surface that are leaking. So it's really important to correlate your clinical findings and not always go on angiogram. So this is really the reverse. And again, this is the fellow eye of the same patient, not picked up on angiogram, but picked up on OCT. This is a 4-year-old who presented with bilateral combined central retinal venous occlusion and central retinal artery occlusion. The child had an acute exacerbation of a nephrotic syndrome. Fortunately, as you can see in that picture, there was cilioretinal artery sparing, and the child recovered to 6/12 after about 7 or 8 months. This picture is borrowed from Mike Treacy, and what's important here is the capillary hemangioma looks scary, medusa head, but really important for us as ophthalmologists to refer back to the pediatric neurologist, because a lot of these conditions have midbrain abnormalities which have to be co-managed. Coming now to the ROP part, where FFA really holds a strong point is in cases which require pre-treatment or follow-up after anti-VEGF. Now, in this condition, this baby was injected more than 4 months back elsewhere. And you can see these pre-retinal lesions sort of almost sitting on like epiretinal membrane-like things, these white spots. And we would have thought that they would light up on angiogram, but clearly it doesn't. What looks like an immature retina is actually avascular periphery. And you see this leading edge, which is leaking. So this is where you know, and this is 360 degrees. This term now has, this entity now has a new name in the new classification, which is persistent peripheral avascular retina. And we know, of course, that it must be lasered. And angiogram can help you exactly delineate till where you need to laser, and it's very accurate, heals very well. And if you do the angio about 6 to 8 weeks after the initial treatment, you can see its resolution. Sometimes you get a recurrence which is more like this, which is a classical stage 3 recurrence after the initial angiogram, after the initial anti-VEGF, and this is not throughout. So you see a stage 3 kind of recurrence in the upper temporal quadrant, but a more diffuse kind of leakage in the superior area. And again, when you look nasally, it looks more classical. So again, angiogram helps you pick up which parts are leaking more profusely for more posterior laser, and which are more the blunted leakage where you can just go up till the edge. Again, the important thing is to do the laser thoroughly, and in some cases you might actually need to laser on the NVE, and as you can see in the follow-up angiograms, these then completely resolve. What was the old NVE actually then starts just floating up, as you can probably appreciate at about 10 or 11 o'clock in the top picture. This is a case that was injected almost a year back in one state, then migrated to another state, was lasered. But you can see that, I mean, don't look at the angiogram first, just look at the RETCAM picture. It looks fairly okay, except that the laser marks look scattered and probably irregular. The retina itself, except that upper nasal front, looks like, okay, this could just be followed up. But we'll be so wrong if we don't assess this fully. And you can see then the angiogram, because of the skip areas or the inadequately done laser, look at the activity. And this is 1 year after the initial injection of aggressive ROP. So this really requires a very thorough, complete laser, and angiogram, again, of course, can help you decide till where and till how much. And this is a follow-up angiogram, which almost shows complete resolution of the NV, except that one little posterior front here, which had to be then lasered subsequently just on that area to finally give a complete resolution. This is one of our pictures from one of our publications to show that the capillary non-perfusion in aggressive ROP, earlier called aggressive posterior ROP, and one of the reasons why it's now called aggressive ROP with the drop of the word posterior is because of this panel below, where the CNP areas can exist and can occur so much more anteriorly. And while we are trying to focus on what's going on posteriorly, a majority of the pathology is actually happening much more anteriorly. And it's so important to recognize this and then treat. In recent advances, I really want to talk about our little bit of experience in doing OCT angiography in these babies. This was our very first case report where we looked at OCT angiography to not only realize that this flat new vessels in aggressive ROP was not on the surface, but way deeper. And if you selectively laser that, and you can see on the follow-up OCT angiography that all the deep new vessels really disappear. And then we had a more follow-up study on these slightly older infants on OCT angiography and found that the FAZ and the deep capillary plexus look so different in 6, 9 or better vision children between the age of 5 and 10, just because they had historical ROP. So their vision could be normal. Ophthalmoscopically, they can be normal, but on OCT angiography, they show abnormal deep capillary and superficially capillary plexus. So that's really a subclinical viewing of what's going on in these small retinas. And this is some software that we started playing around with to give us an angiography-like picture, but without the dye. And this is the standard picture, and this is what's called the vesselness protocol. And you can see the smaller capillaries go beyond, which we would have picked up on an angiogram, but not without a dye. So this is one of those software-related enhanced dye-less angiography studies. And you can see this on the left is the original, the native image, and the software is played around. You can see the occluded vessels much better in the red-free picture there on top and the vesselness protocol below. Similarly, with the occluded artery baby, which I showed you before, and you can see the cilioretinal artery sparing in the enhanced pictures. The importance, and this is my last slide, the importance of the fact that angiography is coming to stay now in infant imaging is the fact that it has made a mention in the international classification of ROP that was released last year. In fact, the whole spectrum of aggressive ROP has been rewritten just to show us that capillary non-perfusion that can be picked up better on angiogram than clinically is now going to be probably a new way of not only following up these conditions, but perhaps even in diagnosing it and treating these conditions. Thank you very much.
Very amazing talk, Dr. Anand. Really, truly enjoyed it. Excellent talk. And look forward to discussion by Dr. Anand Rajendran.
Yeah, as usual, an excellent talk. It's always a pleasure listening to you on pediatric retinal diseases. Just like to add that you almost covered the entire spectrum. Something that we've learned from experience from Bascom Palmer about FEVR, exudative retinopathy versus ROP. This ROP roper that we've learning to kind of understand a little better. Your experience is that the fact that ultrawide field can show you these tangled vessels which in a very atypical way pop up into the peripheral vascular zone, the vascular segmentations. Your experience with this, and how often, like on a scale of 0 to 100, would you expect to see that in our population?
Honestly, we've not done such a large-scale study to talk about percentages, but definitely, as you said, the features are slightly different. Many times, and consanguinity is very, very common in Karnataka and probably in Tamil Nadu as well. So one always has at the back of the mind that this could be an FEVR variant, and especially when these babies are nearly at the borderline of 2 kilos. But I think what sets it apart, other than the vitreous pathology, is the fact that the plus disease is so much lesser compared to the disproportionate amount of disease that's there in the periphery. So the fibrovascular, the vitreous pathology is so bad looking in the periphery, but when you look at the posterior pole, there's hardly much, in comparison, the plus is not so severe. So this is one of those places where your antennae go up and you're like, are you dealing with a roper? And many of them don't really have that stormy postnatal course, but honestly, it's just not possible to be absolutely sure until we do the genetic study.
Sure. Also, just a question, and also comment. I think earlier, it was a little misunderstanding. I mean, when I meant multicolor imaging, I meant, of course, red free for retinal, but with multicolor imaging, you also get a look at the vitreoretinal phase also. That aside, but also, I just want a lot of the action is in the periphery. So how far do you see for a new setup investing in technology and imaging technology, ultra wide field, angiography, feeding of what Ashay said, how useful and how impactful will it be for a modern retinal practice going forwards, and also ultra wide field OCT angiography? And also in your cases, did you use the flying baby technique for most of this advanced imaging?
So I think a wide field Optos-like angiography for pediatric retinal conditions is a blessing, is a boon, but if you don't have it, you can still really do a good job. Just to tell you what Mike Treacy does nowadays, he says, all his FEVR cases, he follows up 6 monthly or annually only on wide field angiography. So I think that is probably where we all need to aim at. But even with the 120, 130 degrees, what you get with a Neo or a RetCam, fairly sufficient to come up with a conclusion, conclusively what we can see and do. Only thing, because it's a contact camera, it's very difficult to do it in a slightly older child. Flying baby, yes, we did it for that first case report. It was an 8-week-old child and it had aggressive ROP. But for that subsequent paper that we published, which I showed the screenshot of, they were all 5 to 10-year-olds. We chose that because we wanted to correlate the FAZ with their vision and their so-called normal-looking macula. So there we did not need any flying baby. They just sat at the Heidelberg and we got that.
Sir, I had one very quick question. When you do the angiography, especially when you have a zone 1 or a zone 2 and you're given anti-VEGF, and we know that after 4 weeks, there is no much progression. But a few of the authors, I don't remember the exact name, they have described that if it tried to progress with at least 2 disc size, 2 disc diameters of the size from what the original ridge was, and if it doesn't progress more than that, then usually these are the cases of recurrence and these require a second anti-VEGF therapy. So how long would you wait? And if you want to document it doing an angiography in the first instance, and then you give an anti-VEGF and then you again document it and you see that there is only 1 disc diameter of movement of the edge what was there before. So what are your treatment conditions? Would you like to repeat angiography in these cases, or you straight away go ahead for laser?
Okay, so great question. And not all those questions have been answered worldwide. So I'll give you the general consensus and what we are doing in India through, let's say, the IROP Society, general consensus. So as far as pre-anti-VEGF angio, if you are going to do, you're really going to do it if to decide does capillary non-perfusion in the macula fovea or not. If the CNP in the fovea, it's a great candidate for anti-VEGF. If there's some amount of capillaries in the macula, you might even want to go with laser, but that's a separate discussion. Now, what happens as far as the growth happens? So once you give the injection, it depends on which drug. If you're giving ranibizumab, the progress is much slower, recurrences are much faster. And by faster, I mean sometimes between 2 weeks and 4 weeks. If you're giving bevacizumab, which is Avastin, the recurrences happen much later, sometimes 12, 16 weeks, and as reports go, even 2 and 3 years later. So the question is, how long are you willing to wait? So if there's a recurrence anytime, whether it's 1 week, 2 weeks, or 10 months, you're going to treat. There's no question about it. And most of us, and I would say 99% of Indian ROP specialists will do it with laser and not with a second injection. Now, what happens if there's no recurrence, but the blood vessels are simply growing forward ahead? Then, yeah, that's where the consensus is not there. But what are we generally looking at? We want the vessels to at least grow into zone 2 anterior. That would be our aim. Once it grows into zone 2 anterior, we are like, okay, we've saved a decent amount of retinal real estate. Now let's go ahead and laser. But what if the baby is now 10 kilos by then? That means you'll have to laser under general anesthesia. Do you have the facility for GA? Is the child systemically okay to sustain GA? So therefore the question comes, and I sort of written a small editorial in IGO on this. There are about 7 or 8 factors what we might consider on when we go ahead and do the second treatment. So the weight of the child, the age of the child, the drug use, the dosage used, and if you have the angiogram, to look at the edge leakage. If the edge is leaking and the blood vessels have reached zone 2 anterior and the child is about 4 or 5 kgs, and that's your comfort zone of doing it under topical anesthesia, I would say do it. So 52 weeks should be your cutoff, which is 3 months from the due date. 40 weeks being the due date. So if you're at 52 weeks, normal fovealization and peripheral vascularization should have ideally occurred. And if it isn't, by now the child is about 5.5 kilos. So if you're comfortable doing the laser, go ahead and do it then. If you're fairly confident of following up the baby for another 8 weeks, then do it under general anesthesia. Most people in the West would wait till about 55 or 60 weeks. Here in India, we do it somewhere between 48 and 52 weeks. Sorry for the long answer, but this is where the consensus is.
It is a question of debate, because many Westerners have started doing second dose of injection, third dose of injection. But in India, I think the consequences are different, as you rightly explained it. Thank you.
Thank you very much, Dr. Anand. So we shall go on to our last speaker, Dr. Unnikrishan Nair, who is the Medical Director and Senior Consultant of Chaitanya Group of Eye Hospitals, and deals with a lot of subspecialties, vitreoretina, uvea, neuro-ophthalm, and electrodiagnostics. And he is going to be talking on OCTA, differential analysis of vascular plexus and vascular pathology.
And I would also like to thank him, because we discussed these topics with him and he was very supportive. And thank you, Dr. Uni sir, for your contributions as well. Thank you.
Thank you for the invitation. And Srinivas told me to talk about something different, basically, that is understanding artifacts rather than the vascular plexus. There's a small change in the topic also. So I'll just share things over here and share. And okay. So this is a typical slide that we all use to talk about OCTA. That is, it's a repetitive scan, and the difference between the two scans is what brings out the imaging in OCTA. So I'd like to say that there are rules of imaging. There's an object to be imaged and an image to be acquired. And the rules of imaging tell you that there are going to be problems happening, and those are called artifacts. And you have to respect and know those artifacts if you have to interpret the image. So essentially, understanding the technology means you also have to understand the failure of technology. And when it comes to OCTA, you have to know how the flow is detected, what is the difference between the B scans, what are the problems. So you have to know what are the problems created during the capture, what the software does to help you and to make life difficult for you, what you see, and eventually how to incorporate understanding these artifacts into what you interpret. So this is a very basic presentation, and we're going to look at the artifacts as 4. The first is what we call bulk motion artifact. So this is a very historic picture. It's called Pendulum on a Ship. the gentleman is Christian. What he decided was that if you put a pendulum on a ship and it swings properly, you could actually determine latitude using it. Okay, so the problem in Octa is the same thing. A pendulum on a ship on a smooth sea is okay; it goes regularly. But if the sea is also rough, your pendulum varies in time. So this is the pendulum of the ship, and it's the same thing. And why does this happen? For an Octa, first the scan has to go through a raster. It has to fly back to the original position, and then it has to scan again. So you have a TS, which is T scanning, and a flyback time, or TF. And the interscan time, the total time between the scan, is the time between the scanning time and the flyback time. So why is this important? If you shorten the interscan time, the time between two scans, you may miss the time for the motion to have happened. That is the RBC to have moved. You might have missed it. So the sensitivity comes down. If you increase the interscan times, you will pick up movement better, because the RBC would have passed on. You would pick up and say, okay, a flow has happened. But the longer you push the interscan times, the more the eye or the more the imaging system is prone to movement. That is, movement will affect the scanning protocol. So shorter interscan times, it's less sensitive. Longer, you open the eye to bulk eye movement. So this is what we said. If you have a longer time, you have the ability to pick flow, but the system gets saturated very early. Okay. Now, what I'm going to do is a small summary of the saying is that if you want to pick up the slowest possible flow, you have to have a longer interscan time. But the problem is that they get saturated. So the color of the scan, if it's more white, it just simply does not mean that the flow is more. That's how an OCTA works. And as I said, when the movement of the eye, the head, or the body, because of longer interscan time affect, it's called motion artifacts. And there are a couple of types of motions, that is the artifacts that are produced by motion directly, as you see, and or the artifacts that are produced because the system or the software corrects for the motion. And you see breaks in the pictures like that. So basic motion artifacts, we're talking about two or three artifacts. One is the white line artifact. The second is the vessel doubling. You have a stretch artifact. These pictures show it. The white line artifact is the one you see here. The motion is translated to a signal, that is a white line. The second image you have at the edges, because of long interscanner, you have stretching of the image, stretching of, you can see on the right hand side. These are called stretch artifacts. This is called a kiloting artifact, where you have a rectangular, a tile or a snake-like pattern happening. And the lower image is because of a doubling, a vessel doubling artifact. And all these are because of motion. Now there are a few.
Srinivas? I'm not able to see his presentation. All of you are there?
His bandwidth was very low. I think his voice was also getting distorted. I think his internet connection was not that
He's
great.
come back. He's come back. Yes.
How is it now?
Yeah. Yes. Yes.
How is it now?
No, you will have to share your screen again.
Yeah. Okay. Are we okay?
Yeah. We need to
Can
see.
you hear me?
We can hear you. Maybe what you can do is you switch off
Okay.
your video and present your thing, because the network is not good. Yes, we
Okay,
can
you
see.
hear me now?
Yes, yes.
Okay. So there are a couple of artifacts that happen without major movement. That is, you have, because of small changes like lipid particles moving in a cystoid macular edema, or reflections that happen off the wall of a cystoid macular edema, gives a false impression of blood vessels. So these are two other types of motion artifacts. And the new terminology that has come is suspended particles in motion, that is lipid particles in cystoid spaces. Interestingly, there are micro movements inside the eye, like the pulsation of the choroidal lobules, or artifacts produced by the curvature of the eye. And these are called Z-axis motion artifacts, which produce white lines whether or not there. The second type of artifact would be attenuation. So every system has got a threshold. why do you need a threshold in a system is that you have to eliminate all the unnecessary noise or signals, and then only the signal becomes good enough to interpret. So what is the problem of this is that when the threshold removes a signal and it recognizes as an absence of flow in an octa, you have to differentiate it from an actual attenuation of the signal. That's called the attenuation artifact. So if you have a local opacity and it blocks the information coming back to the transducers, and it blocks it to the interferometer, then there in which you have a blockage. So here you can see there is a dark line artifact, and if you also have a recognition of what causes it, you will know that these artifacts, the black artifacts, are because of an attenuation of the signal. And therefore you get false positive and false negatives. As false positive, you get, as we said, various decorrelation signals produces a white artifact where there is no flow, and the false negative is what we are talking about, the attenuation artifact. We'll go to segmentation errors. So I'm just going to show you, this is a picture of macular telangiectasia. You have various level of vascular changes. In the what do you say, a vascular zone, you don't see in any image over there corresponding to another image where this is in the deep venous plexus itself. You see a lot of vascular images, and you see the CM in the avascular zone. Why I showed this was that we have basically two visualization patterns for octa, that is a cross-sectional and an emphase. And why is this important? Why did I show you those images? You can imagine that we are converting a three-dimensional image of octa or a data flow into a two-dimensional emphase, and we're interpreting it. So we are presuming a few things. We're presuming that you're accumulating a lot of blood vessel layers based on only the segmentation into one image. You're losing depth information sometimes when the segmentation volume is not properly done. Two things we have to realize: that nature may not always put all the retinal layers according to a textbook picture. Your normal vasculature may go among various retinal layers, and your segmentation may not be a true representation of what the nature intended. And the second point is that alterations that happen in pathology because of swelling of the retina cystoids, the RPE pushing up, can all change your interpretation of vasculature. So there are risks of segmentation. So if you can see this particular image, you can see that the same CNVM in two different segmentations show, one shows a larger involvement than the second. So these are the what improper segmentation can do. Besides that, it can cause appearance of abnormal anastomosis, a merger of vessels, and underperfused tissue because of improper segmentation. So this is just a simple drawing. I said, if you take the segmentation through the center, you get a large CNVM. If you take the segmentation lines to the top of it, you get a smaller CNVM. This would be very important when you're doing a review. Also, segmentation artifacts happen when there's gross pathological changes or anatomical changes in which you have no control over the segmentation lines. Okay, this is an example where the vasculature is totally distorted when you, in highly myopic eyes, when you take the segmentation is quite difficult to do sometimes. These are other examples of segmentation errors when there's a PED, the segmentation lines go all over the place, probably cutting the PED in some cases, and sometimes not giving you proper vascular information. So these are other things where slab thicknesses also affect. You can see basically non-interpretable choroidal vascular image. You can't find out whether there's a CNVM in the midst of that. A few small clues is that obviously you can do manual segmentation, which is a very tedious job, but sometimes you can even choose for smaller scans in which they concur to the contour of the RP or the contour of the pathology better. The last is a projection artifact, in which it's a very interesting thing is that it's also called a decorrelation tail, where you get a projection of a superficial layer, or sometimes a deeper layer into superficial, or vice versa also. And it causes a false vascular image. And this is why it happens. Basically, it's like any projector system where you have a lamp which causes, and it causes a shadow on a screen, which is a projection screen. What happens here? When light passes through the retina, it gets modified by retinal structures. Some light is reflected back and taken back by the interferometer and interpreted. Some light passes through. The light that passes through carries the legacy of the, the structure above it, and it projects onto the screen. The screen can be the RP, it can be choroid in a very thin retina. And what happens when that happens is that you get the vasculature of a tissue lying above, of a vasculature of a vessel lying above in a deeper layer where you do not expect it to be there. And this becomes critical when you're looking at very fine vascular pathology like CNVMs and all those things. So as I said, there are lamps. The choriocapillary is a lamp, and you have screens that the plexiform layers, the RP and the sclera screens, in which generally you can have projection artifacts to a deeper layer. Here you can see in the center of the FAZ, you have a vascular loop, which is, and you can see it over here, and that is an example of a projection artifact. There are ways to get around projection. That is, you look at the octa image and you subtract it. There's a probabilistic approach for each layer. You see whether the probability of the next layer having that particular, vascular structure is there or not, and then the machine does an approach to remove it. That's called PAR, or projection artifact removal, or projection resolved octa. So you can see here, you can see a lot of blood vessels here. In the next picture, all of those blood vessels are removed, and that's what a PAR on and off does. So essentially, the most important thing about PAR is that you have a co-registration. That is, multiple scanning protocols have to be included. You need an NFAS, a cross-sectional OCT, a cross-sectional octa, and an NFAS octa. And when you have a co-registration,
1 minute remaining, sir.
Okay, I'm nearly done. The other thing is that as a person interpreting the image, you have to sequentially check each layer and also look at the structure flow correlation. That is your cross-sectional octa, and also related to the structural OCT, to make sure what vascular structure is there. Is it there structurally? Do you get a cross-sectional flow? This is an example where you see some blood vessels in the periphery, but it's essentially it's a cyst which has put the blood vessels, and you know there is no vascular structure there. You can correlate it with the structure flow. You don't get the vertical elevation of the vascular events. This is my last slide. I'd like to say that one of the things that people say is good about octa is that you can do it as many times and review the lesions as far as possible. Here is where the artifacts and the image interpretation is important. When you do a review scan, you have to check these things. You have to check the plane of the scan and the horizontality of scanning. If it is not a horizontal scan, the second time, you're going to get different information of the data. You've got to check whether the contour is changed and whether the contour is comparable between two scans. Obviously, you have to check the segmentation. You have to check the slab size. If you cannot compare a thin slab on one with a thick slab on another, you'll incorporate more vascular data on the thick slab. You have to check for image quality to rule out attenuation artifacts, and you should not say that there is no flow where it was actually an artifact, and you should always check between the layers to know whether there's been a projection of a vascular event on a deeper layer. Thank you for that, and I'd like to say that just informing you of the Retina Imaging Congress, which we're going to have on the 22nd of July this year, and I'm inviting you all for that. Thank you so much for the patience.
Thank you very much, Dr. Undi. It's I think a very complex, challenging talk, and hats off to you.
Thank you so much.
I want to ask him whether he has done any engineering degree, because I suspect he's doing some engineering degree in the evening time.
The innovative man. Sir, one question is, when MPSR was telling in the elevated lesion, you need to do a segmentation. Any specific tips you have, especially when you have a large elevated lesion, how to go about with the segmentation in those cases? Manual segmentation.
First recruit your most diligent resident. Make him sit in front of the machine. Ask him to change 50 scans according to the contour of the retina. Come back in the evening and apply the segmentation to it. That is it is a meticulous job. It is, if you're seeing about 60, 70 patients in OPD, you're not going to have time for it. You need somebody to sit and change 50 scans. And when that is done, you can reap the benefits looking at it. That's all.
Practice makes man perfect. Yeah.
Or have residents and fellows here.
Yeah, what Undi has said, it's so important, so meticulous. If you have a subtle lesion which you are suspecting, it's so important to have all the 3 slabs at your view, both all the on-fast structural B scan and the vascular flow. All these 3 has to be correlated by the doctor if you have a subtle lesion like what Dr. Srinivas was asking. So that gives the depth and the contour and the vascularity. So unless you correlate, because of this segmentation issues and all these things, what Unni has beautifully shown, there's a high chance that we can go wrong. So all these 3 slabs has to be seen at the same time.
I believe there is going to be a consensus eventually on the Octa, how to present an Octa report like we have HFAs, very standard things. There is going to be a very standard way of interpreting or putting up Octas. Without it, we won't be able to compare.
Yes, in the new publications that we are submitting, all the 3, that's what I was trying to say, all the 3 sections have to be submitted. Just one vascular slab and trying to say this vascular. So that vascular slab, the on-fast slab and the structural B scan, all the 3 has to be submitted, both for horizontal and vertical. So that only gives a realistic and logistic view of for the viewer or to understand the depth of the lesion.
Thank you very much. I hope in the process you all don't start over-diagnosing this condition. I just wondered. So, Srinivas, should I conclude now?
Yes, madam.
So first and foremost, I think it goes without saying that it's been a truly amazing webinar, and hats off to Srinivas for evolving the idea of doing this, and an amazing set of speakers and just superb expert panel where the discussions were so ultimate and just exactly what everybody who has not watched it should go back and watch and learn a lot of it. And we have created our ARC website, or rather in the process of completing it, where all of these great sessions are going to be compiled and can be used for future reference. Thank you one and all. Thanks a lot, Srinivas, as my co-moderator, and it's been an amazing learning experience for me. And thanks to my ARC members as always. Special thanks are due to Kripal and the AIOS team for always being there, very supportive. Thanks to Dr. Anand Sethi and his team. You can see how meticulously these webinars are being conducted, and how even till 8:45, Sharik is so sincere and committed about telling the time delay. And thanks a lot to Sai and Manjula from Numerotech for all those mails which keep bombarding your mailbox. And finally, and most importantly, thanks are due to Entor for being absolutely staunch supporters for our ARC programs. And I think my gratitude with them cannot be expressed in mere words. And I think if we are what we are, it's because of all our attendees who watch these programs. And I think we owe our thanks to them for ARC to evolve to whatever stage it has come up to. Thank you, one and all of you. Thank you.
Thank you, Chitra.
Thank you, everyone. Thank you.
Thank you, Chitra and Srinivas and the team
you,
ARC.
Thank you.
Thank you, everyone, for the excellent discussion and the excellent talks.